Καλή σας ημέρα. Είμαι η Έλενα
Good morning. I'm Elena Papadimitriou, and I'd like to welcome you to the event organized by FairLife Lung Cancer Screening Program in Greece. Are we ready? Lung cancer prevention and early diagnosis. Are we ready? Yes, we are ready today to kick off with this significant discussion. We are ready to listen to scientists, to raise awareness, to listen to proposals and recommendations. We're ready to learn what we should know in today's event organized by FairLife. Before we move on, we have to let you know of two things. The first one being that in order to organize this event, we have abided by all health safety protocols and all due examinations and tests. And the second thing is about interpretation. Those of you who attend from their home, etc., you can find the globe icon at the lower part of your screen, and by selecting it, you can select the language you want to hear. Now, we have Ms. Corina Patelli-Bell, President of FairLife, and recently elected member of LUCE, the Lung Cancer Europe organization. Good morning. Good morning to you all, and have a nice week. Dear friends of FairLife, I'd like to welcome you and thank you wholeheartedly for your presence here in today's event. This first event organized by FairLife, celebrating its 12 months of operation and action. As you might know, regarding the establishment of FairLife, well, it all started following the death of my husband Simon at the age of 57. Simon fought with lung cancer in a very difficult and unfair and unequal battle. And I stress the term unequal because although he had the will to put up a fight, having by his side excellent doctors in his family who supported him till the end, he had not many alternatives. Innovative drugs, although they are at an advanced stage of clinical trials abroad, remain inaccessible to patients in our country. Only few clinical studies take place. Bureaucracy and the legislative framework exclude access to drugs that might be the only proposed and recommended treatment for patients, as was the case with my husband. Nowadays, we have recent new therapeutic options through individualized treatment and targeted treatment, allowing patients to live longer and maybe heal. So throughout this whole course, I stood by his side. I accompanied him in his radiation treatments, transfusions, travels abroad, and I know too well about the anxiety of waiting for the results and the effort to identify recent treatments. Many times I wondered why we didn't make it. What was it that we didn't do? Why our strenuous efforts to have access to innovative drugs were unsuccessful? Simon didn't have the time. He wasn't able, and he wasn't given the opportunity. He wasn't given a chance. Had Simon had been given a chance, today he would be the founder of FairLife, and he would make a vision come true for a world without lung cancer. He could be in my position supporting patients suffering from lung cancer throughout this whole difficult course. So he would be here to raise awareness on prevention and early diagnosis. Prevention and early diagnosis may sound like a wish list. I wish I had prevented the growth of cancer. The answer is that you can make it. Do not postpone your tests. Anyone with a lung might fall ill to lung cancer. Screening with low-dose CT may help us diagnose and identify early lung cancer, and it allows us to have better therapeutic options such as surgery, aiming at complete healing and cure. Now, early diagnosis and prevention should constitute a priority for our national health system. However, here we are to discuss whether lung cancer screening program is something that we can accept in Greece. The answer will be given by the study of the Health Institute and our distinguished guests. Our aim is to use the data in order to formulate a national proposal for early screening for lung cancer in order for us to do what's best to achieve a world where there won't be many patients suffering from lung cancer. Concluding, I'd like to thank once again the board of directors, the scientific team, our special experts, volunteers, friends, scientific societies, patients advocates and societies, the mass media, the supporters of FairLife, and the sponsors of today's event who have supported us in this whole effort with their contribution and the support of everyone. FairLife today celebrates 365 days of action. Now, before I conclude, allow me to devote today's event to my children Melina, 17 years old, and Eric, 13 years old, and to all children in the world with a wish by my daughter. I wish no child in this world lost their parent to lung cancer. Prevention saves lives. Dear Corina, we warmly thank you. 365 days of FairLife action, as Ms. Patelli said. Let's see what has taken place throughout these 365 days.
FairLife.
FairLife, lung care, cancer care and prevention in memory of Simon Bell. A year ago, my life partner, Simon Bell, 57 years of age, father of our two wonderful children, lost his life to lung cancer. The pain of his loss became the seed of creation of FairLife, the first non-profit social organization exclusively dedicated to lung cancer. Greece ranks last on the list regarding lung cancer diagnosis. The Greek national health system lags seriously behind. Up to 2020, there was no organized lung cancer patients association. FairLife comes to fill this gap so as to represent patients in the dialogue with all relevant institutions, as well as participate in decision-making for lung cancer treatment in Greece. FairLife aims to assist in lung cancer early diagnosis and treatment by properly informing the public, by carrying out screening tests in high-risk groups, and by supporting patients and their relatives throughout the course of the disease. Our vision is to save as many human lives as possible through screening programs, as well as to facilitate the pathway for lung cancer patients and their families. FairLife collaborates with over 70 scientific experts in the public and private sector in Greece and abroad. FairLife is a member of 6 national and international bodies. It collaborates with 10 scientific teams in Greece and abroad. From the start, FairLife has been warmly supported by all medical associations. FairLife's board of directors consists of members with strong professional backgrounds recognized as experts in their respective field. Our effort at FairLife is to ensure that health information by reputable and distinguished scientists is accessible to everyone. helping to detect lung cancer at an early stage through low-dose CT screening. By introducing the section Learn, Act, Hope, FairLife hopes to answer key questions and issues aiming to improve patients' quality of life so that they gain valuable time, so that they are able to participate in treatment, ask the right questions, and get the answers that will help them throughout their treatment. We share knowledge and work closely together with the right people in order to achieve common goals for the overall benefit. We have more than 100 volunteers willing to contribute to all of our actions, while having already gained a large number of partners through continuous and consistent presence. FairLife's ambassadors accompany and assist the organization in its effort. Anastasia Gerolmatou, Kikitsa Kaldimi, Nikos Magitsis, and Orestis Fotis Michelakis. Warmest thanks to our supporters and to all those who contributed to this very important effort. We are grateful. FairLife, within a year of presence, has participated in online campaigns and screening programs, spreading the message of early diagnosis, as well as in anti-smoking actions, raising awareness and encouraging outdoor activities in nature. In the context of the social contribution, Lungs Health screening program is being offered for free to vulnerable social groups. In May 2021, FairLife's president was elected as a member of the board in Lung Cancer Europe. She has been elected as treasurer. She's also patient research advocate of the IASLC STARS program.
This program organized by International Association of Study of Lung Cancer.
Η FairLife παρέχει την αιγίδα σε κάθε
Actions and events held by organizations aiming to inform the public and raise awareness, as well as support patients and their caregivers, are under the auspices of FairLife. From the very beginning, FairLife has an ongoing presence in scientific conferences and events, thus creating every possible connection and collaboration for the benefit of Greek lung cancer patients. Many thanks to Ms. Zoe Gramatoglou for inviting me to this online conference. There are many things that have taken place within this past year, organized by FairLife, and if we consider that out of all these 12 months, at least 6 were under lockdown status, well, you can understand how valuable such actions have been. Today, during this event, we put to good use our technology in order to allow for the participation of distinguished scientists from around the world, either through Zoom or by videos. So we're going to start with a video by Dr. Heather Wakely, President of the International Association for the Study of Lung Cancer, Professor at Stanford University, an oncologist, so IASLC.
Lung cancer-focused medical oncologist at Stanford University in the United States, and president of the International Association for the Study of Lung Cancer, IASLC. IASLC is the only global organization dedicated to conquering thoracic malignancies worldwide. We bring together basic scientists, surgeons, pulmonologists, patient advocates, nurses, oncologists, and many others, all with a vision shared with the participants in this symposium, to see a world free of lung cancer. I am honored to have been invited to participate in this FairLife lung cancer care, lung cancer screening program. I wish I could be with all of you in Athens. I am delighted to join you virtually to focus on the critical topic of lung cancer screening in Greece. It is particularly fitting that this conference is happening in November, Lung Cancer Awareness Month. For lung cancer awareness, we use a clear or white ribbon to represent air and the lungs, but also because lung cancer has been the invisible cancer. Despite being the #1 cancer killer for men and women in the United States and much of Europe, lung cancer is often not highlighted for many reasons, particularly stigma. Yet advances in lung cancer treatment have led to significant improvements in cancer mortality overall. The advances in targeted therapy and immune therapy for lung cancer have made global headlines. But the biggest impact we can have on lung cancer mortality, besides prevention, is the implementation of lung cancer screening. Lung cancer screening saves lives. This has been proven in multiple well-conducted randomized trials in various areas in the world. This conference will focus on research specific to the implementation of lung cancer screening in Greece. When lung cancer screening is implemented, lung cancer is detected early when cure is far more possible. When we think about the progress and the prospects for early detection in lung cancer, we think about impacting the lives of thousands of people. While IASLC focuses on many aspects of lung cancer, we consider screening one of the most important strategies in the war against lung cancer. I am delighted to see the work being done by FairLife and so many medical societies, patient advocacy groups, and others focusing on lung cancer screening in Greece. Thank you.
Και εμείς ευχαριστούμε και καλημέρα.
We thank you too, and would like to say good morning to Ms. Evelina Smita, Vice President of Lung Cancer Europe.
The floor is yours.
Hello, my name is Evelina Schmetke, and I'm a volunteer in lung cancer advocacy for over 15 years. My role in Lung Cancer Europe is the Vice President, and I'm honored to represent Lucha in this event and support FairLife, one of our full members in this initiative focused on lung cancer screening. Lung Cancer Europe is the voice of lung cancer patients, their families, and survivors at the European level. Lucha provides a European platform for already existing lung cancer patient advocacy groups and supports the establishment of a national lung cancer patient groups in different European countries where such groups do not yet exist. Lung Cancer Europe represents 20 countries by 19 full members, national organizations, and 14 associated members. We aim to raise awareness about inequities in access to lung cancer treatment and care in Europe. Moreover, we advocate European policies that will lead to improvements in lung cancer prevention, early detection, treatment, and care. Our objectives are to reduce the mortality of lung cancer, to promote the best possible treatment of different types of lung cancer, equal access to lung cancer care throughout Europe, raise public awareness for lung cancer about symptoms, early detection and treatment, reduce the stigma associated with lung cancer, and more compassion for lung cancer patients and their loved ones. Increase European funding allocated to lung cancer research. In this sense, I'm very glad to see an initiative like this one organized by FairLife, which is the first non-profit organization in Greece exclusively dedicated to lung cancer. Screening is a very important topic, having in mind lung cancer, as this, apart from prevention of lung cancer, is the most vital action that may influence the treatment care pathway for people impacted by this disease. Advancement in lung cancer research has provided greater insights into the disease, allowing for the development of new treatments which can provide improved outcomes for those living with lung cancer. Despite this, lung cancer remains amongst the highest contributor to cancer-related deaths in Europe, responsible for almost 1 in every 5 of all cancer-related deaths. It is well known that early diagnosis is an important step towards improving survival and quality of life. However, most lung cancer diagnoses are often made at late stage when the disease has spread to another part of the body, thus impacting survival. This is caused by a lack of awareness of lung cancer symptoms, as well as risk factors linked to the disease among both the general population and healthcare professionals. Sometimes lung cancer doesn't have any persisting symptoms until the disease has developed to an advanced stage. In other cases, symptoms can be non-specific and people may experience many symptoms at the same time. Additionally, a lack of systematic lung cancer screening across Europe is contributing to late diagnosis. Lung Cancer Europe developed Get Check campaign that aims to increase public awareness of signs, symptoms, and not so well-known risk factors associated to lung cancer. The campaign was launched this November, the Lung Cancer Awareness Month, and is endorsed by European Lung Foundation, European Respiratory Society, and the European Patient Forum. I am very happy to inform that this important raising awareness campaign will also be promoted in Greece by FairLife due to Lung Cancer Awareness Month activities of the organization. In the end of my speech, I would like to congratulate the president of FairLife, Corina Patelli-Bell, on this important event that brings together many different stakeholders to speak about such an important aspect of lung cancer care in Greece. Thank you again for having me here, and I wish everyone a fruitful meeting. Thank you.
Awareness, awareness. This is one of the many messages we need to take home following Mrs. Smitske's presentation. And with that, I'd like to say good morning to Ms. Mina Gaga, Deputy Minister of Health. So, Ms. Gaga will be joining us in a few minutes. Good morning. Good morning. Good morning, Ms. Gaga. You have the floor. First and foremost, I'd like to thank you for the invitation. It's a great pleasure for me to be with you here today. And I see in the panel many friends, not only from Greece, but also from Europe, such as Dr. Bloom, who is in the European Lung Cancer team, Evelina and Jeanette, working together with the European Lung Foundation, actively dealing with lung cancer, and all our friends, Ms. Apostolidi, and colleagues, Mr. Tavernarakis, Mr. Mouzakas, of course, our rector, Mr. Dimopoulos. So we are talking about a panel of friends, people with whom we have worked for many years against lung cancer. I see my own partners, Lefteris Zervas, etc. I think that it's really important. In Greece, lung cancer is the first cause of death of mortality due to cancer, as is the case in the rest of the world. And we have many smokers. This is why we have so many cases. And we have a very late diagnosis, so it is important for us to have an early diagnosis. In Greece, the good thing is that we can have easily patients undergo CT scans, but this has to be incorporated in a well-structured diagnosis program with specific protocols for diagnosis, specific multidisciplinary teams to evaluate and assess the findings of the CT scans, and a structured pathway for patients. who are with symptoms and who need to be diagnosed. If the diagnosis is positive, then we need to have the whole course of care and treatment. So it is important for us to have a very well-structured plan and program, both for awareness raising as well as timely diagnosis, early diagnosis, a specific plan and program that will involve all interested parties, doctors, nurses, radiologists, pulmonologists, psychologists, right from the start, supportive treatment as of day one, all these things that we need to have, which exist in small islets, but still not part of a structured program. So from this position in the ministry, we work together with the National Health Organization, trying to build such a program in cooperation with the Greek Respiratory Society. Mr. Dimopoulos is head of the oncology team in the National Health Organization. So we will move forward all together. To us in the ministry, this is an important challenge, an important objective. We have the Apostolos Doxiadis program ushering a new era for the screening of other cancers, breast cancer, intestinal cancer, etc. But lung cancer is something that we need to be working on. So we will advance together, and I'm really glad to hear about this initiative by FairLife. We are in constant contact with all of the available organizations, and we will move on. Thank you very much. Thank you very much, Ms. Gaga. This is a happy conjuncture because we have the Minister of Health being a pulmonologist, and it is of an extra value nowadays with this important effort undertaken by FairLife through this event on a screening program for lung cancer in Greece. So now we say good morning to Mr. Meletis Athanasios Dimopoulos, Rector of the National and Capodistrian University of Athens. Mr. Dimopoulos, you have the floor. Good morning, have a nice week, and I'd like to thank you for this kind invitation. Allow me to say that indeed this is a very significant conjuncture and opportunity with FairLife being so active in its efforts in parallel with the presence of the Deputy Minister, Ms. Gaga. As you know, aside from being a very well-experienced pulmonologist, aside from her significant interest demonstrated regarding the diagnosis and treatment of lung cancer, with the deployment of a state-of-the-art diagnostic laboratory, she has significant experience having held administrative positions in Europe. So this means that Ms. Gaga is a competent person to speak with at a European level. Let me also point out that there is also another positive fact. The presence in the Attica region of a respiratory diseases specific hospital, Soteria Hospital, which has many patients who are screened for lung cancer. The upgrading and modernization of this hospital is yet another positive action within the pandemic. In Greece, we have high rates of smokers, and it takes special care and raising awareness in schools and adolescents. We see a reduction of smoking in the past few years, but it is not equally as important as in other states. In the States, for instance, in the United States of America, on the basis of recent data from the American Society of Oncology Research, we see that there has been a drop of lung cancer mortality rates. What we currently need in Greece, and we need to join forces towards this direction, is aside from raising awareness and prevention, we need a timely diagnosis, as the Minister put it, it is important for us to set criteria for the reimbursement of screening tests, such as the low-dose CT test. And it is also important to spread further this diagnostic algorithm by optimizing and upgrading labs that lead us to diagnosis. We are aware of the special bronchoscopy techniques that allow us to diagnose lung cancer even at the stage of a very small lesion. The third element that we currently need is to further strengthen this therapeutic algorithm in the sense of providing appropriate tests with the use of two prognostic indicators or indices. We need to have liquid biopsies. We need to establish this when we don't have accessible material, and we need to set in place therapeutic protocols that will be strengthened, that will be followed, and this will allow us to better treat lung cancer patients. We are optimistic vis-à-vis lung cancer because we see that there has been a significant improvement in patient survival, even when the disease is diagnosed at a metastatic stage. We do have immunologic therapies and targeted therapies that allow us to treat advanced stage disease and range from this to the adjuvant treatment, the adjuvant therapy. So I think that we can be optimistic that we can make a difference in Greece regarding a disease with such a high incidence and which constitutes a serious health issue in Greece. Within this framework, FairLife's initiative is particularly significant in order to mobilize patients, their families, and in general to spread the word regarding the significance of prevention and early diagnosis in lung cancer. Thank you very much. Thank you very much, dear Rector. So Mr. Dimopoulos talked about tools and instruments pertaining to prevention, early diagnosis. And in this way, we set the foundations to move on with this discussion. However, in my job, in journalism, in the news, we always say that data on their own are not enough to let people understand and grasp the meaning. We need to have stories, personal stories, because this is how you identify with patients, this is how you feel and you can understand. So with Mr. Tsimaras Zanatos, who is a writer and an actor, he is going to share with us his own story. It is important for us to listen to him narrate his own story.
Thank you very much. Nice to see you. It's nice to have you. I have a story to tell, a chronicle. And do I need to come to the podium? No, you can stay there. You're fine there. Great. The important thing is to be able to tell a story and to share it with others. So I'm going to tell you my story in a simple way. One day, I started losing my voice. I talked, but my voice was not the same. It had a different color, a different timbre, and no metal. Afterwards, I found it difficult to use my voice and to reach tones or semitones. Being an actor, I realized that my main tool, my voice, had been affected by something I did not know. And this, from the moment that I opened my eyes every day, put me through a nightmarish procedure. I went to an ENT doctor, I went to a special voice doctor, I ran some tests. There seemed to be nothing wrong with my vocal cords. They said everything was fine. This lasted for many months, and things got worse all the time. I was an addicted smoker. I actually started smoking when I was 14. And my favorite photograph was the one you see. That's me as a child with a cigarette in my mouth, smiling, getting ready to enter the world of adults. And then I suddenly decided to quit smoking. I started using heated tobacco. Then my voice gets worse. I switched to vaping, same thing. I then used nicotine patches for months, and then I almost quit smoking completely. But my voice didn't go back to normal. It wasn't just difficult to talk. It was even difficult to breathe when I was talking or singing. I spoke and I had to use a diaphragmatic type of breathing, and the respiratory function was severely impaired, and I started falling apart physically and mentally. Having had depression in the past, I thought this was just a psychosomatic symptom which I couldn't control. I started talking about it, I asked around, I get no definitive diagnosis. The answer was, you're stressed. But this situation lasted for over a year, and I tried to find information, and suddenly I found an article talking about a type of partial paresis of the vocal cords, which was possibly linked to the lungs. My GP and very close trusted friend, Stelios Mastorondonakis, referred me to a pulmonologist. Spirometry test only. So the spirometry test shows the first stage of COPD, of an early stage, which is normal for a smoker like me. He gives me some kind of inhaled medication to use on a daily basis, morning and night. 3 months go by, nothing has changed. I insist that there's something else happening to my lungs. I go to a phonologist, and he said, it's all due to stress. Relax, Mr. Zanatos. I asked my GP to tell me what kind of lung tests are recommended. He says, CT of the lungs, he said. This is the end of January 2021. All of a sudden, I start feeling happy. This lasted for just a number of days. It was as if I was recovering from a physical breakdown. I do the CT. I get the results a couple of days later, and there is a carcinoma in the right lung. I no longer feel happy, and I start thinking, and this thought comes to my mind, and it's just like a child thinking, won't I ever be happy again? My pulmonologist refers me to an expert whom he trusts blindly, Grigoris Stratakos, at the Soteria Hospital. I manage somehow to book an appointment. I see somebody who's very gifted. He tells me that it's very serious. He says it's cancer. He suggests PETs, a full-body CT scan, a brain MRI. I do them all immediately. And, of course, everything had to be done through ICA, my Social Security fund. Otherwise, I wouldn't be able to afford these tests. And according to the test results, there's a malignant adenocarcinoma in the right lung without metastases, which is the only good thing. Then we do a bronchoscopy with Stratakos. Stratakos sees everything, and he actually shows me the points where the small carcinomas are to be found in my lung. I still hold it. It's a little sketch, and he said biopsy for a possible immunotherapy. The facts are not good. We need an oncologist with the help of Stratakos, whom I now call by his first name, Grigoris. He finds me an associate of his in Soteria. His name is Yannis Gozos. We started chemotherapy sessions. And beginning of February, I'm happy, and I meet Corina Patelli-Bell at the phase I'm ready to start radiation treatment. She helps and intervenes so that I can meet Mr. Pisakas at Alexandra Hospital, a great man with great moral ethics. And he says, I will now become your doctor. The period of chemotherapy, and there were 4 chemo sessions, and make me understand what it means to be alive in hell. I call this condition the Lazarus condition, who does not react to Christ's voice, Lazarus, come forth. My doctor for radiation treatment was similar to the doctor who helped me with the chemo. Her name is Mariangela Kalogeridi, a lovely lady. 30 radiation treatment sessions, and at the same time chemo, and mid-June, when all the treatment is complete. I really feel terrible after doing so much chemotherapy. And somebody says to me, it's it's mid-June, summer. Everybody says, be careful, don't stay in the sun too long. For 2 months, everybody thinks I'm on holiday. I'm recovering from a terrible condition where I had lost myself. I smile, but it's just a reflex, even to the people around me, to the people I love. All this time, I realized that none of the first doctors, the pulmonologists, the NT doctors, the voice doctors, had not recommended that I do a screening test. A lung CT scan. If I hadn't insisted, I wouldn't have found out up to now that I had cancer. So without the lung CT, I might have found out about it many years later when it would have been too late for me. So I was asked to tell my story. I told you my story. So it's important to be able to tell a story. First of all, it means, first and foremost, to be able to say it to somebody else, that you address other people. So this addressing the other makes us move away from our individual egos, and it means that we meet others, that we become one, that we become a small community. A community, a society like the one we're all building today together. And I'd written some time ago, there is a Z in the Greek word zoe, the Greek word for life, which is constantly buzzing. It does not leave us alone in our deathly silence. Thank God, I say. Thank you very much for allowing me to be here in front of you. And I would like to thank you from the bottom of my lungs.
Lazarus too has a Z in it, and you are here indeed, and your story is really valuable regarding this significant discussion that we are introducing today. We thank you warmly. If we had an audience here, I think that they would proceed to a standing ovation. Thank you very much. Thank you. Now, let's move on to see how FairLife this entire month is in action, is close to you, and it is realizing its trajectory to raise awareness by conveying the message and spreading the message on lung cancer prevention and how early diagnosis can be a key to save lives.
Όλο τον Νοέμβριο, μήνα ευαισθητοποίησης.
Throughout November, Lung Cancer Awareness Month, FairLife organizes a series of events on November 6 and 7. The new institution has been inaugurated as Clipia in action, aiming to promote the message of well-being as a means to provide prevention, early diagnosis and support. On November 15, FairLife holds its first conference entitled Lung Cancer Prevention and Early Diagnosis, which presents the results of a study on lung cancer screening conducted by the Institute of Health Policy. Throughout November, with actions in the social media, we are in actions and we join our voices through the internet to support those who are patients and to remember those who have left us. FairLife joins the European Luther campaign, Get Checked, promoting this same campaign in Greece. Simon has been the inspiration for FairLife. The bane of his loss became a seed of hope and of creating an ideal world. I wish no child in this world lost their parent to lung cancer. Prevention saves lives. Let life take your breath away, not lung cancer.
And
so in action everywhere. in action in Trikala as well. We'll see what took place in Trikala during the Asclepia in action in the city of Trikala and in the events organized by FairLife there.
Η ζωή.
Let life take your breath away, not lung cancer. A marvelous message and excellent initiatives or action that took place a few days ago in Trikala. Let's move on, though. Let's see about the findings of the first research pertaining to screening. This will help us launch a discussion and will pave the path. So this is why I would like to introduce to you Ms. Evi Hatziandreou, Doctor of Public Health from the University of Harvard, Vice President of FairLife, Mr. Kyriakos Souliotis, Professor of Health Policy, Dean of the Faculty of Social and Political Sciences at the University of Peloponnese, and Ms. Elena Linardou, Medical Oncologist, Board Member of FairLife and Director of the 4th Oncology Department of Metropolitan Hospital, President of the Scientific Committee, ECOG. Now, welcome, good morning. People will start commenting immediately after our discussion. We will have as guests in the next session to be coordinated by Ms. Nelly Kapsi. So we'll have the speakers, Mr. Torsten Gerrit Blum, Head of the Thoracic Oncology Assembly, European Respiratory Society, Ms. Zenia Saridaki, Medical Oncologist, President of the Hellenic Society of Medical Oncology, Mr. Stelios Zervas, Professor of the 7th Clinic of Soteria Hospital, Mr. Kyriakos Souliotis, Professor of General Practice and Primary Healthcare, Director of the Clinic of Social and Family Medicine, School of Medicine. We see you all. Mr. Christoforos Foroulis, Professor of Thoracic Surgery at the Aristotle University Medical School and President of the Hellenic Society of Thoracic and Cardiovascular Surgeons. Ms. Kyriaki Tavernaraki, Radiologist, Registrar the first Department of Imaging and Interventional Radiology at Sotiria Hospital and Secretary General of the Hellenic Radiological Society, and Mr. Georgios Pisakas, Radiation Oncologist, Coordinator Director, Radiation Oncology Department at Alexandra Hospital, and Vice President of the Hellenic Society of Radiation Oncology. So welcome you all. Good morning. You will have the opportunity to discuss on the basis of the findings of the research that is going to be presented immediately, starting with Ms. Hatziandreou. Thank you very much, Ms. Papadimitriou. Dear friends, I'll start my presentation, and first and foremost, I'd like to apologize to colleagues because many of the things I'm going to mention are already known, but since we are addressing ourselves to patients and their family members and to the broader public, today I want us to present the relevant documentation vis-à-vis a correct and appropriate health policy vis-à-vis lung cancer. This is why I will very briefly mention issues of public health, prevention, the dimensions thereof. I will focus on the excellent program that has already been announced, the Spiros Doxiadis program, and take a quick look at the future. Public health, on the basis of the CDC definition, is both an art and a science. It's not simply a science. It possesses basic fundamental scientific foundations. We have epidemiology, together with all of the workshops and laboratories, plus informatics that have entered our lives. At the same time, it is combined with surveillance, epidemiologic surveillance. All this leads to knowledge that will help us deal with prevention. However, before I move on, please take a look at this pie, the factors determining the health of a population. You'll see that the genes and biology account for a relatively small factor, then followed by care, medical care, but what mostly affects health is our behavior, together with the broader social, societal environment. So all these most important factors are under our control. So prevention has three levels. It pertains to population, the broad population, those who suffer from the disease without knowing it, and those who are already diagnosed, where we try to limit and mitigate the consequences. We have primary prevention when we deal with a population in order to prevent the disease. In case of the manifestation of the disease, we're talking about a secondary prevention, trying to identify it as soon as possible, and tertiary prevention, interventions aiming at preventing consequences and sequelae. Now, I'd like us to focus, this is from the recent Eurostat data. In red, we see the amount spent for prevention. 2.8 on average, 70% goes for treatment. 2.8% is even lower than expenses for the administration of public health services. This is a very low rate, which needs to change. So screening aims at exactly this. We move directly to prevention, trying to identify early enough the disease or the risk factors in the broader population and trace them and identify them in order to move on to a definite diagnosis and subsequent treatment. Why is that? Because early diagnosis saves lives. Not all diseases are prone to screening. There should be criteria met. We need to have appropriate documentation, data proving that this kind of screening is efficient. Moreover, benefits are many more than secondary effects or disadvantages. And the disease has to be severe, and there have to be means to deal with it. This screening test should be simple, reliable, with high sensitivity and specificity, and screening should be economically efficient. This has to do with the entire documentation that we will be offering through this event. So this is why we're offering all this documentation, to put in practice this vision. So a simple balance. There are benefits because we can reduce severity, reduce mortality. However, there are harms such as false positives or false negatives, the diversion of health resources, etc. So we need to strike a proper balance in order to have a good health policy. The fact that there is some kind of screening does not necessarily mean that everyone does it, everybody does it. This is the breadth, the width of the population undergoing several types of screening tests. Out of 25% screening on depression to children vaccinations, reaching 100%. Mammograms for breast cancer, it's somewhere close to 70%. The minister actually put it, it is not enough for us to simply establish a screening. We need to raise awareness of the people so that they get the screening tests. Europe has started institutionalizing the Beating Cancer Plan. You can see 4 out of 10 cancer cases are preventable. 40% of us all run a risk of cancer in our lifetime. Therefore, there are many things we can do. A few statistics. Out of all causes of mortality in the EU, 25 to 26% pertains to cancer. And the cancer with the killer cancer amongst cancer is lung cancer. 5% of the overall number of deaths. So 1 in 5 patients die to lung cancer, not because it's the one with the highest prevalence, but because it's the more deadly cancer. So far, there have been many means to deal with that. Let's see what happens in Greece and the alarms. Crisis in the past few years, from 2008 to 2018, due to anti-smoking campaigns, etc., we have had a drop of smoking rates. However, in red, you can see that we are champions in Europe. Out of 40, we dropped to 35. This whole part, in the coming years, a large percentage of this population will give us lung cancer. So this is a reality, and we need to mitigate this and to prevent early enough the patients with whom we see early signs. Here is the picture in Greece, approximately 9,000 cases on an annual basis. We said that this is fatal. We have a higher percentage of deaths as compared to breast cancer. On a global scale, you see in blue the incidence of breast cancer, but the deadlier one is lung cancer. So, if we take all this into consideration, it becomes quite clear that the adoption and implementation of a screening program will be significant because it will lead to early diagnosis and better treatment. There are challenges. The minister mentioned it already. She stole our thunder. Whatever we had to present to you has already been mentioned by her, but we were glad to hear her because she is very familiar with the subject. So we need to have infrastructure, we need to make sure that there's quality, raise awareness, and increase knowledge. Now, this is the law that at last establishes a public health program, the cost being approximately 1 billion for the upcoming 5 years. So we have primary, secondary action, prevention actions. We have specific programs for the identification of cancers, cardiovascular risk, and ventricular aorta aneurysm. Let me point out that we already know that on the basis of the data I've shared with you and the ones that Mr. Souliotis and Ms. Linardo are going to present, lung cancer has all necessary documentation to be included in the Spyros Doxiadis program. Advice. In the UK, there is the National Screening Commission. I suppose that this is what KESI stands for here in Greece, which advises regarding the screening programs. So look, in the future, as we speak, we do have the means. There are recent treatments upcoming, and medicine has been turned into the 4 Ps medicine: predict, prevent, personalize, and participate. That is, patients, healthy citizens participate in the procedure as soon as they fall ill. So there are ways, maybe easier ways, and I believe that we will be able to identify them pretty soon. One of them is the liquid biopsy with a blood test that can identify corpuscles of the mass that may not be seen in X-rays or CT scans. There are other unconventional ways. There are studies showing that specifically trained dogs, this is a study in 2021, at a percentage of 73%, sniffer dogs can identify lung cancer patients from breath. Already, there are companies such as this one. This is a paper, an article published in September. We have this startup company having collected $58 million to find a tool to identify early lung diagnosis. But we are ready to start. It's a great honor and pleasure for us to be given this opportunity to contribute with our knowledge. Thank you very much for your attention.
I would say that nobody stole the thunder. Mrs. Gaga did not steal the thunder. I think she paved the way so that we could continue this discussion. That's the right way to put it. Thank you very much. Mr. Souliotis, you have the floor. I'm going to remove my face mask. So good morning, ladies and gentlemen. I would like to thank you for inviting me to speak in this alliance of the willing, because that's how I see it. The 3 people sitting here, the previous speakers, Corina, they're all behind this effort, and I feel it is great that I am participating. Of course, the thunder was stolen by the sniffer dogs. I wish I could experience the moment when the sniffer dog will actually discover this, and then if this is prescribed, that would be great. I'm going to try it out with my own dog. Now, what we do, in my mind, may seem important because it comes to a country where there's a lack of data. We're called to quantify and document what everybody knows, that prevention saves lives. We're talking about high mortality. The relative mortality can be avoided. It can be prevented. I'd like to see my slides because I couldn't see my slides before. I think it's impossible. I can't make out what's written. Can this go back? Can I go back? Because these are the wrong slides. So I'm going to make a brief introduction. My introduction is about the pandemic, because everything we're now discussing, we're discussing them at a very strange period, at a strange set of circumstances for our healthcare system. So it ushers in a new world. It is not an exaggeration to say that pandemic will change the way in which we see health, the health policy, the healthcare system, but also other manifestations related to our daily lives. The world will be different, but there's some positive elements. One of these pros, if you like, or positive elements is that light will be shed on health-related issues. We've become more sensitive relating to health. We understand how important it is to have a well-functioning healthcare system, how important it is to have a social life, and so on and so forth. All this being said, I think it's a great opportunity for us to fill the gaps that we had in the health policy for many years. This is from a recent project, and I just want to say that according to Pavlos Tsimas, the world will be different. But let's see how different, and let's try to make this a positive thing. So we see that there's more pressure on the healthcare sector. Of course, the money is limited, despite the fact that the fiscal discipline has been relaxed, it's been eased. But we also have the adoption of some factors that may increase the risk of dying. So I think we need to take action quickly. We need to have the right reflexes in order to provide answers to the challenges we're facing. So in the pandemic, we saw other things as well. In Europe, we see that it's difficult for the citizens to access the healthcare system, maybe because the healthcare system focuses mainly on COVID patients, but also because people are scared to get into contact with the healthcare system. We see that 51% say that it's moderately difficult to have access to healthcare, 19% that it's very difficult, 44% that there is a delay or obstacle. So the fact that the pandemic is evolving doesn't mean that people suffering from other diseases have solved their problems or that they don't need healthcare services. And this is a very worrying phenomenon. 1 in 4 in Greece says that they have unmet medical needs. In our study, 37% found it difficult to have access to the first contact point between the citizen and the healthcare system. So we don't have a good pathway which ensures timely diagnosis. And this is linked to what I'm about to say. So in cancer, there are references all over Europe that show that cancer diagnoses have fallen by 39%. Of course, these people will be diagnosed at a later stage, so they will need more costly services and more technologically demanding services. So from studies, we've seen that prevention, for example, women being screened for breast cancer has dropped in the last 2 years because of the pandemic. Why? Because there's a fear that they might get infected with COVID-19 if they go for screening. So we see that research is evolving, new treatments are being put to the test, they offer better outcomes. So we see that even in the case of lung cancer, this of course requires money. 100 billion in Europe is invested in cancer treatment. This is a high number. The systems can pay this cost, provided, of course, certain tools are used, mentioned by Mrs. Hatziandreou. We are more expensive than the EU average for a number of reasons. I would like to believe that this lag is also linked to the late diagnosis. So I think what we're discussing now is of critical importance. I'm not going to give you the epidemiology of cancer. Many experts have already mentioned that. We have 8,960 new cases of cancer diagnosed every year, and here you can see the mortality. Mrs. Hatziandreou said that lung cancer is inextricably linked to smoking, and in Mrs. Hatziandreou's study there is a detail. There is no difference according to the educational level. Why? Because smoking habits, they're addicting, and it's got nothing to do with how much you know, with your level of knowledge. Nobody can support that there's a lack of knowledge. It's not that people don't know about the harmful effect of smoking. They know that it's bad, but they can't quit. We have a reduction of number of people smoking, but we need to do more. Of course, we have the anti-smoking law, which has helped reduce the number of smokers. Of course, early diagnosis can help lives, and this is the base of our approach. And here we have our screening model. And of course, timely diagnosis also offers an opportunity to make more rational use of resources, because the faster the diagnosis, the easier to handle the problem. Even though we don't have a lot of data, we have measured the end-of-life healthcare cost, and I'd like to say that it increases exponentially. And this is why we're saying that we have the existing scenario, the existing tests which are based more on the symptom or some chance, if you like, test, and so on and so forth. And we built a model. I'm going to leave the methodological data because they're rather tiring. And let me just show you the model. This is the diagram. You have to see the patients. The cohort is 100,000. We had many simulations, and we had some working assumptions. One is that health people will be tested 1 year later in order for us to see whether they develop symptoms. Now, a second assumption, a second working assumption, which has some basis, is that the patients who have symptoms will enter treatment and they will be better. So we have the experts, we have the capacity, we have the doctors who can handle patients who enter into a treatment phase. So we have the clinicians, we have the experts. This is something that came out of the project. So the diagnosed will immediately enter treatment. There will be no gap here. Now, there are asymptomatic patients. Now, the model says a test every 3 months. And this is very good, and there are many simulations. So these people will either develop symptoms. The probability is based on international literature. Unfortunately, we don't have Greek data. And the asymptomatic patients, on the basis of the model, have a small likelihood of being diagnosed by chance. 3.8% approximately may undergo a test, a chest X-ray, a CT scan, because, for example, they were given a new job and they need to do some tests, and that's how they somehow find out that they have a problem and must be treated. Now, these patients can either remain in the same stage, or they may develop symptoms, or may move on to the next stage, so that they will then be checked again against the new stage, or they may die. So I'm going to move along these slides very quickly. And we intend to publish this model. It's the first that this study has been ever conducted. And here you see the clinicians. They actually classified the patients into the different stages. And here we see that 3.84% will be discovered by chance. So we went from, it's a bottom-up approach. We know how many CT scans are carried out per year, how many are to find if there's cancer or not, those that are actually carrying out follow-up CTs, and so on and so forth. So based on the information provided by the clinicians, we saw what the percentages are, what the parameters are, and what the values are. So here, very analytically, there's a lot of information per stage, and you have the distribution of patients based on the clinician's information. And here you can see the difference between the blue and the red outline, which means that if we have universal screening, we will have a shift of patients to early stages. And this is what we want, because sooner or later, these patients will develop symptoms and they will diagnose. But what we want is with screening, not to wait for the symptoms to appear. We want to catch them early. What does this mean in Greek? There were 100,000 patients. We would have had a reduction of the number of deaths by 24%, which is a very high number, and a number of lost years of life due to lung cancer by 30.90%. This is the result from the chance, if you like, screening in these people. So we will save 339 people, and there will be 944 less years lost. So if we carry out the extrapolation, we did this without the stochastic model, directly with the classification provided by the clinician. So in the population that we have, we calculated that the deaths that we will save in the 5-year period is 3,500, and the life years will be 9,000. So this means that the result of this screening is huge. Please allow me to tell you a couple of things, and these will be then commented by the next speaker. So from other studies in the literature, we see the same results, the same conclusions. So our percentages are close to those of other countries. But if we think of how many people smoke in Greece, the percentage of smokers, you understand that we will have an even bigger impact of this screening program on the population. And this is good for health expenditure as well, because what we're interested in the next phase is to see how much money we need and how much money we will save thanks to screening. This is something we want to look into. So we want to see what result this screening program would have. So 3,500 lives in a 5-year period may seem like a small number because we're talking about a pandemic. COVID has acquainted us with the idea of death. But what we're looking at and what COVID have in common is that we can avoid these deaths from taking place. So I'd like to convey a message after thanking our clinical experts and all the other associates. 6 people worked very hard in order for us to have the result, together with the 10 clinical experts. Here are the acknowledgements. So, together with the inclusion of screening into the Doxiadis program, which is a great program, I also want to convey a message for vaccines. It's a shame to have people dying every day for something that can be avoided through vaccination. So, coronavirus is something that we've only known for 2 years, whereas lung cancer is something that we've had for a long, long time. Mrs. Linardo, you have the floor. Those of you watching us can continue sending questions to the speakers in the chat room. Thank you.
Good morning from me as well. Thank you very much. It's a great pleasure for me to be here amongst friends and partners and visionaries with whom we share the common vision. Ms. Hatziandreou has already set the landscape. You heard Mr. Souliotis talking about the results and findings of the first and only research on the value of screening in lung cancer. And now it's my turn to complete the list of data, which will help us answer the question as to whether we are ready in Greece to have a lung cancer screening program. I believe that to the question why we need lung cancer screening, the answer is quite easy. We've already given you all the data. We're dealing with a fatal disease, which is responsible for, as a first cause of death, cancer-related deaths. In Greece, we lose 7,500, 7,600 lives lost every year in Greece. And The tragic thing is that lung cancer is usually diagnosed. 7 out of 10 patients will be diagnosed with an advanced stage. In lung cancer, every centimeter counts. As you'll see in this transparency, the curves represent 5 years survival, depending on the stage. The higher the curve, the better the survival. If you see the top curve, the blue one, this represents survivors diagnosed at stage 1 of lung cancer, the initial stage. So you see that if a lung cancer is diagnosed at a very early stage, 9 out of 10 of the patients will have more than 5 years survival. However, if it is diagnosed at advanced stages, you can see the other side of the coin. If it's diagnosed at a stage 4, only 1 out of 10 will make it to 5 years, despite the great advances in therapeutics. And of course, smoking. We keep on telling you about it. Unfortunately, we rank first in the statistics. We remain the first country in cigarette consumption and the second one in tobacco consumption amongst Western European countries. And unfortunately, this is a country with the highest number of lung cancer deaths in ages under 45. And as Ms. Hatziandreou said, this is to be seen in the future because the next generations will be bound to suffer from this lung cancer pandemic because, unfortunately, many of our children, 3 in 4 children in Greece, up to a few years ago, are passive smokers. We once believed that things have improved lately. What do we know about lung cancer screening so far? It's important to know what happens globally. So it all started somewhere in the 90s, following the first publications that X-rays or CT scans could be significant to diagnose early lung cancer stages, and these led to the highest funding operation in the National Lung Screening Trial, which included 53,000 participants. It all started in 2002, and it has been the largest randomized trial in lung cancer. What has it shown? If we use low-dose CT as compared to the conventional CT for screening, we can diagnose a lot more lung cancer cases, and this can be seen on the left in the transparency, and in extension have many fewer deaths. 20% reduction, 1 out of 5 can be prevented using this method. I'm not only talking about lung cancer deaths, but 6.7% reduction of all-cause mortality. Because as you can understand, a CT scan does not have lung cancer only as a finding. It might help us identify many different problems. The second study is the Nelson trial. This is a European trial. It was launched in the Netherlands and Belgium with 15,000 patients, individuals who were included, screening versus no screening, and we have really impressive results. 24% reduction in lung cancer mortality with the use of low-dose CT. What's most impressive about this trial is that this reduction was even higher amongst female participants, 33%. So women smokers may benefit a lot more from the screening programs. This has to be taken into consideration in our plans. Many other studies, we have had 9 randomized trials. This is the most recent one. It was announced within the global lung cancer, the World Lung Cancer Conference from the UK, and it has shown that using low-dose CT may save lives. Other problems? Ms. Hatziandreou, yes, touched upon it. Definitely one of the biggest problems is whether with the low-dose CT we're going to have false positive findings, which might lead, aside from stress and anxiety, which might lead to unnecessary tests and investigations, or even unnecessary surgical operations. How can this be reduced? Using protocols, algorithms, standardized incorporation of all these guidelines to all screening centers. And of course, this will reduce overdiagnosis. In trials, we were talking only about 3% of overdiagnosis. Other important issues: who is to be screened? Who is the high-risk patient? Nowadays, there are many models and very simple criteria we can select. Lung cancer screening is not as with breast mammogram. It pertains to a specific high-risk population, and it is important to see how often we should undergo the screening. There are several periods mentioned in the trials. It seems that the predominant period is on an annual basis. Cost effectiveness. We've already heard Mr. Souliotis. It is important to know that there have been many trials throughout the world, both in the US as well as in Europe. Usually these are studies on the basis of theoretical models. Out of all these studies, the outcomes show that the strategies used in the big clinical trials are indeed cost-effective. But please bear this in mind. The strategies of trials are cost-effective, and this is important as to the way we design our programs. What do we add with this study, which is the one and only study in our country and one of the few in the world using such a model, giving us an answer on the effect of screening and saving lives. Our findings, if we compare them to the two large studies, despite the fact that there are differences in the criteria we used, different age criteria, because we were based on the most recent data. However, both our model as well as our clinical studies show that low-dose CT scan may reduce by 24% lung cancer-related deaths. It may reduce lives lost by 30.9%, and it may provide many different diagnoses at earlier stages. And as we said, every centimeter counts. These are the criteria used for our own trial, and these are the ones recommended globally in all the health systems where we study the way with which we select the patients. Others use multifactorial models. However, the simplest way is to select on the basis of age and smoking history. And it should be an annual screening. So we're talking about adults, smokers, aged 50 to 80 years, with a history of smoking, 20 years, or who have quit smoking in the past 15 years. They need to be screened annually. So where do we currently stand? It's not so much of a question whether as to where this screening works. No, it needs to be implemented. And the question is not whether we should screen, but how we can do this effectively. This is where we currently stand. We don't need any more clinical trials in our country. We don't need further research. We do have the data. We need to implement things. Already, globally, in the States, there are national programs for lung cancer screening in South Korea and Poland. These are the programs applied for lung cancer screening so far, but there are also other pilot projects in many different European countries, such as the UK, the Netherlands, Israel, etc. In the UK, what is important to see is the model that we've been using. They didn't use the lung cancer screening test. They used the model of lung health check. This is important because this will help us approach people. It will help us identify other morbidity factors, and it will help people visit doctors easily. So they run pilot projects in industrial areas such as Liverpool, Nottingham, Manchester, etc., with high-risk populations, smokers populations, which led to this national program, which is nowadays supported by the NHS in the UK, which is a targeted lung health check program. This uses these imaginative messages come for an MOT for your lungs, a technical control for your lungs. It speaks the language of these people to approach them, and it goes close to them. They've been using mobile units with mobile CT scanners in supermarket parking lots. These are very nice approaches indeed, with any significant effect in the UK, which led to convince the National Health Policy to fund and finance a countrywide program. What does the country do? It takes action. We saw that the European program Beating Cancer includes and involves many messages and many different guidelines as to screening in all the EU countries. And of course, there are many issues still. One of the most important ones are the protocols, the guidelines, and quality assurance. No one can plan a screening program without organizing a central quality assurance system. And what's most important is that we cannot think of having in place a screening program that does not include smoking cessation interventions. If we add screening to smoking cessation intervention, we have a further reduction of mortality. It rises up to 38%, and as we heard from the Minister, quite correctly, screening for lung cancer is not just a test. It doesn't mean that we'll be pleased tomorrow morning if we have a reimbursement for the low-dose CT scan. This is not what lung cancer screening is all about. It is an entire process, and it should be such. It should be such a process if we want to reproduce the very good data we saw in clinical trials. Otherwise, we won't be cost-effective. Can we do this? What I'm showing you here, the transparency. Can we have a screening test associated with primary care, whereby high-risk patients will be tested? There is going to be a risk assessment. Then they're going to undergo a low-dose CT scan. They're going to discuss about smoking cessation, and then an interdisciplinary team will deal correctly and efficiently with the findings of the low-dose CT. And what's most important, we need to have a recall somewhere in this model. This is why we need to have a database and a program. There's no point in undergoing a CT scan which will have no finding and come after 5 years to repeat the CT. It has to be repeated annually. So we need to change the situation, and I will conclude telling you that we are in a position to achieve this in Greece as we speak. There's a recent Greek initiative for which I'm really proud. There's the first organized lung cancer screening program in Greece, which is in operation at the Metropolitan Hospital for the past few months. We have called it lung health test, and this is offered for free to our low-income fellow citizens who are unemployed through the FairLife social program. So there are many fellow citizens who have taken part in the program. Their data have been entered into the database. What do? We hold once a week outpatient office every Monday. We assess the risk. We discuss with the patient. We include them in the program. We enter their data in a database. We help them get linked to the smoking cessation or the COPD practice. There is a low-dose CT scan. We inform them on the results and we give them a follow-up plan. If we have pathological findings, there is an interdisciplinary council which once a week will let the participant know what they need to do from now on. And we'll have a recall in 1 year's time if we have normal findings. So let us answer this question, and I give you these two last transparencies for our speakers. Are we ready in Greece? What do we have? Definitely there is international documentation. There's experience that we can take advantage of. We can tap into experience. We do have the scientific evidence. Screening saves lives. There's a reduction of lung cancer deaths by 24%. We've seen this from this trial. We hope that soon it will be published. We do have the know-how. We do have the scientific proficiency. We do have the support from scientific societies who have submitted their proposals, such as the National Action Plan on lung cancer. And we do have IT systems and digital health systems that we can use to establish the necessary structures for such kind of problems. What do we need? We need to organize special lung cancer screening centers, as with the case of mammograms. So we had the need for breast cancer centers. We need lung cancer centers that will provide LVCTs, that will include and involve smoking cessation practices and pulmonary nodules assessment centers. These have to be certified and have a central quality assurance organized. We need the equipment and training, and we need to have a plan to identify high-risk smokers. Therefore, we need to have lung cancer established as a priority within the National Action Plan on Public Health. And I think that one of the main conclusions of today's event could be an agreement by all organizations to include lung cancer screening in the National Prevention Program of Spiros Doxiadis. And I'd like to conclude thanking the volunteers team of the EIA program. We have come in contact with public organizations and agencies to collaborate and have a common intervention. Thank you.
Thank you very much. I will try, based on the questions we have received from those watching us, to be able to draw some groups, if you like. And I'm going to start with you, Mr. Hatziandreou. We were in uncharted territory, and now we're starting to map out the waters. This leads us to what Mrs. Linardo and others said, meaning we want to become part of the Doxiadis program. But could you give us more details, more information on what this means in practice, meaning inclusion of screening in the Doxiadis program? What does this mean in practice for the patients, for the citizens, basically? Thank you very much. I'm just going to say a couple of things and then pass the floor to Mrs. Linardo. So this actually means that AOP, the single healthcare provider, will cover screening for everyone. So screening will be free of charge for the citizens according to the correct procedure, which was described by Mrs. Linardo. But I would like to believe, because of the pandemic, I haven't seen that by this screening being part of a national plan, that there will be a campaign, an awareness campaign and communication campaign, not only for the citizens, but also for GPs. And organizing the right infrastructure. We have to have the right support, the right infrastructure in place in order for this to be successful. And the key word is certification and assessment, especially when it comes to health. Let's not do what we did in education and health. Mr. Souliotis, this study, I know that we talked about paving the way for the Doxiadis program, but is it also important because it leads to the mega plan? And here we're talking about a very ambitious plan of the EU, which covers a wide range of needs linked to lung cancer. But does it pave the ways for better absorption of funds and better implementation of all the proposals and the strategies that you have described in the study? Well, when you document something, so documentation, it actually guides choices when it comes to health policy. There are two ways to use intuition to draw up a health policy. But that's not the way. I think when you have documentation, you know exactly what you need to do. We base ourselves on international literature, and many would have said that this might not have been necessary, but we want to quantify what we have before us. The need for such an approach is the fact that we don't have data. We lack data. We're missing data. And maybe a second message that comes out of this is that we need to record things in order to know exactly what we're dealing with. This would make our lives easier, and we have an ally. We see that digitization is very advanced now in the healthcare system. We see that we have the COVID vaccines and everything is digital. And I think it's good because there's already something in place. And as Mrs. Leonardo said, a recall, the follow-up is important in screening programs. I would say that it's just like you have these ads on the pack of cigarettes saying that cancer, smoking kills, it causes cancer, and maybe we could have a 3-digit hot number, meaning it's like MOT. It's not something that we should leave up to chance. Only 3.8% of people find out that they have lung cancer because they underwent other tests for some other reason, rather. And as a journalist, when I heard your findings, I realized that instead of just looking at the entire population, you do things in a more targeted fashion. It's not the same like breast cancer, the mammograms that all women do, and so on and so forth. So this is more targeted. The screening is more targeted. And I think this is key. But this was mentioned by Mrs. Hatziandreou as well. And this is the baton linked to the NHS program. But it's not just enough to have an idea, to have theory. We need to have a mindset change. It needs to become self-evident that this screening is carried out. But there's still a long way to go, a long distance to cover. And you're a scientist, you're a doctor, you're not a communications expert. But I think that without your knowledge and without your experience, we can't actually approach the citizens. You're right, says Mrs. Leonardo. The British can teach us a lot. We have a lot to learn from the UK. They had smoking cessation campaigns, and in many parts of the world, starting from the US and in Greece, you have these horrible pictures of people who are intubated, that have tracheostomy, and these messages are very harsh and horrible to look at. And you know what many smokers do? They actually have a tobacco box or a little box, and they transfuse the cigarettes from the box with all the warnings to something else. But what the Brits do is that they show the nice side of life. They show people going out, having fun, parents going out, working out outdoors, showing beautiful girls eating popcorn and not getting fat. So what they're trying to do is to debunk the messages that are linked to smoking. So you have to show the good side of life, and that's a good thing, because then you dispel these myths about how macho it is, for example, to smoke. So that's why we said that the British messages are the best. And I remember the campaign in southern France in the summer to actually urge young people to get vaccinated. So what they did is they showed young people partying, pairs, kissing, going out for a swim in the sea. So if you get vaccinated, you'll get your life back, you'll feel young again, you'll go out, etc., etc. So they showed the positive things. Now, I don't know if there's anything else, if there's anything that you believe should be mentioned now, and that would be the last time I give you the floor. So what's important, starting from you? An appeal, something that I consider very logical. We should do it right. So let's do everything right this time. Let's get it right. I'm more optimistic this time round for the reasons that were previously discussed, and I think we could have this as a good model when it comes to prevention. Medicine of the 21st century is preventive and participatory in nature. Thank you very much, Mr. Souliotis. I agree. I endorse that. Only 1 out of 4 people go for preventive screening without any signs or symptoms. This is something that should stop. More people should go for screening tests. More people will understand the importance of prevention. It's a good opportunity to start with a program that we can support as of tomorrow. Sometimes we say that there's a time lag between implementation and theory. Now I heard that this can be implemented tomorrow. That's very good. So, Mrs. Leonardo, the reason we're here is to stress the fact that screening, lung screening, can start tomorrow. We don't need any more clinical trials. We don't need any more data. What we need is the will, political will. We have the know-how. We have the scientists. So we need to include the lung screening into the Doxiadis program and start doing these screening tests as of tomorrow. Now I'd like to move on, give the floor to Eli Kapsi. She will be moderating the next session, and we'll see you soon. Thank you. Thank you very much, Eli. I thank everybody. I would also like to announce our speakers. For those of you who have just switched on their computers and are watching us, so we have Dr. Dornton Gerrit Bloom, head of the Thoracic Oncology Assembly of the ERS, European Respiratory Society, Mrs. Zenia Saridaki, medical oncologist, president of EOPE, Mr. Stelios Loukidis, professor of respiratory medicine, president of the Hellenic Thoracic Society, Mr. Christos Leonis, professor of general practice and primary health care, director of the Clinical and Social and Family Medicine School of Medicine, University of Crete, Christoforos Foroulis, professor of thoracic surgery, Aristotle University Medical School, president of the Hellenic Society of Thoracic and Cardiovascular Surgeons, Mrs. Kyriakita Bernaraki, radiologist, registrar A, Department of Imaging and Interventional Radiology, Soteria Hospital, and secretary general of the Hellenic Radiological Society, George Pisakas, radiation oncologist, coordinator, director, radiation oncology department, Alexandra Hospital, and vice president of the Hellenic Society of Radiation Oncology. I would like to begin with Mr. Bloom. Please allow me to ask him in English, and then I will translate it for those of you who don't understand. Thank you.
Mr. Bloom, as the main issue for Greece is the implementation of a national screening program for the early detection of lung cancer, we would like to hear from you about the actions of the European Respiratory Society to support and encourage individual countries to start their own screening programs. Moreover, we would like to hear from you about the idea of implementing a European registry for LCS linked to national registries.
Well, first of all, welcome here from Berlin. I'm very grateful also on behalf of ERF to have been invited to this meeting. And I think it's very important that FairLife has organized such a session on a very crucial topic in lung cancer care. Nelly, I'm sorry, I had a problem because I didn't get your question on English. I only heard the Greek translation. Is there a chance to repeat the question? And I will try to.
Of course, Mr. Bloom. As the main issue for Greece is the implementation of a national screening program for the early detection of lung cancer, we would like to hear from you about the actions of the European Respiratory Society.
Oh, there's also the Greek translation it's louder than your voice.
Ναι, ακούγεται και η ελληνική και τον μπερδεύει. So would the actions of the European Respiratory Society to support and encourage individual countries to start their own screening programs.
Okay, sorry, now I got the question. So first of all, we all at DS were very delighted that lung cancer screening has been mentioned in the first draft within the EU Beating Cancer Plan, which is a really important step, a major breakthrough for lung cancer care as a whole within the EU. So our aim is to keep it at a high level within this EU Beating Cancer Plan. We are all aware that the big three so far are breast, colorectal, and cervical cancer. And currently there's still quite a debate behind the scenes about the status of lung cancer screening. So unfortunately, there hasn't been not only many positive voice favoring lung cancer screening within the EU Beating Cancer Plan at a very prominent level, but unfortunately there are also some negative voices, mainly from politicians that somehow are doubting the value, the evidence, scientific value of low-dose CT lung cancer screening. So ERS has been really active over the last year to promote lung cancer screening within the EU to get it at a high level in the EU Beating Cancer Plan. So our advocacy office in Brussels has been really promoting lung cancer screening over the last year, sending out hundreds of direct personal letters to the members of the European Parliament, convincing and collaborating with other European societies also dedicated to cancer care, convincing them, providing them with the science evidence base for lung cancer screening, which has led to an open letter which has been signed by 50 European but also national societies clearly promoting lung cancer screening. So currently advocacy is one of the major steps that ERS is following to convince the EU Council on the one side. At the end of the day, this will be the platform that will decide on lung cancer screening, whether it will be in the EU Beating Cancer Plan or not at a prominent level, but also the members of Parliament. Some of them have formed the Beating Cancer platform within the EU Parliament. They are currently reading the final version of a final document which comments on the EU Beating Cancer Plan, and within that the cancer screening section is a very important one, and hopefully we will see lung cancer screening at a high level. But over the last years, we have not only promoted advocacy for lung cancer screening within Europe, but also as a scientific society tried to come up or to further build up the science basis, the evidence basis for lung cancer screening. And as you have mentioned, there are various, as we've heard already from the speakers before, there are various initiatives, and I'm very happy to hear that you and Greece are already ready to implement lung cancer screenings. Many other countries in Europe are not. So our mission is also to harmonize and synchronize actions throughout the implementation phase of lung cancer screening programs and to provide the scientific evidence for that. So we have initiated 3 task forces from the European Respiratory Society. The first is to come up with harmonized standards for lung cancer screening. So to provide let's say, a template for lung cancer screening programs that hopefully other countries, nations can adopt throughout Europe. A second task force will deal with the incidental findings. So lung cancer screening will not only detect suspicious findings for lung cancer, but also other incidental findings. Some of them may be important for the patients, highlighting other serious diseases. Many findings will have no significant clinical value, so the second task force will provide another template how to deal with these incidental findings, and the third task force is how to manage the stage 1 NSCLC. As we all hope that lung cancer screening will help to detect lung cancers at a very early curable stage, and the smallest one, we have heard that every centimeter counts. These are the stage 1A tumors, and there we will provide evidence for that.
Thank you very much, Mr. Bloom. Θα ήθελα εδώ να επισημάνω ότι ο κύριος
At this point, I'd like to point out that Mr. Bloom reports that this screening process is important for the identification of other diseases, because we do have low-dose CTs, which allow us to identify other diseases as well. This is what they've been working on. He said that there is a task force that will be dealing with these collateral identification of other diseases that will be identified during the low-dose CT. Thank you very much, Mr. Bloom. Now, I'd like us to move upon the presentation of Ms. Zenia Saridaki, the president of the Hellenic Society of Medical Oncology. Her society is really active in the lung cancer part, and I think that you have drafted a consensus paper with different scientific groups. So, Mrs. Saridaki, give us your own view as to how the Hellenic Society of Medical Oncology will contribute to the implementation of the screening process.
So, good morning, and thank you very much for the invitation so that I can talk about the actions of the Hellenic Society of Medical Oncology, EOPE, based on our knowledge of the situation in Greece, but also the sensitivity of the oncologists together with all those involved, meaning other stakeholders. So we're talking about screening and early diagnosis. So it is within this context that an effort has started. This effort has become more intensive in the last months. And I think that this was in parallel to the European announcement on the action plan against lung cancer in February of 2021, which mentioned very important things regarding prevention and early diagnosis, but also quality treatment and timely treatment. And it took into account important findings, electronic records, patients' records, cancer register, and with a vision that the European Union moves as one country in this matter. So EOPE, the Hellenic Society, particularly in relation to the cancer, lung cancer, and we know that this is a priority in Greece because of the situation. So we see that there is a finalization of a first draft, if you like, of an action plan. Before I say a couple of things that I still can mention, because I can't mention a lot more, I'm not in a position to share everything with you, all the details, but I think that we need to reiterate once again that for the time being, Greece does not have a national action plan for cancer, and lung cancer is one of these types of cancer. So if Greece had an organized action plan, it could reduce the number of deaths from cancer, including lung cancer, and it could have a better quality life, not just for the patients, but also for their carers. The National Register of Neoplasms was set up in 1990, but actually from 2015 henceforth it hasn't been working. The National Institute for Neoplasms was established in 2019, but it still hasn't convened. And the National Doxiadis program, I think that the fact that it doesn't include lung cancer is an omission, and the concept of smoking cessation in primary and secondary prevention accordingly. EOPE, our society, has a vision. So its actions are focused on three things. Less patients with lung cancer in Greece, more patients who are survivors, who survive lung cancer, and a better journey, a better experience for people who have lung cancer in Greece, but also for their families and carers. So the 10 pillars now. We're talking about very targeted. We focus on human needs. We work with all stakeholders, all medical providers and associations, personalization as well. The effort to reduce the time between diagnosis and treatment. So the strategic goals have to do with reducing smoking or the use of tobacco. We want it to be less than 5% by 2040. We want to reduce lung cancer. We want to reduce mortality, increase survival, and better care provided to patients, to lung cancer patients. We believe that through organized programs, like the one that was just described today, through actions at schools, because we are in a position to implement such programs in schools. And I'm talking about raising awareness even in primary schools, because Greece has we have a high percentage of very young children, even below the age of 10, smoking. So I believe that through such actions we will be able to reduce the number of smokers in Greece and the number of children smoking, aged 10 to 14. We want them to adopt a healthy way of life. And the organized screening program with low-dose CT, we believe that this will be able to help us achieve a goal, meaning we want within 5 years to be able to reduce the number of patients with lung cancer in Greece. And we're talking about 10 to 20,000 smokers having undergone a low-dose CT scan. We believe that this will lead to a better way we approach lung cancer. And another important goal has to do with timely diagnosis, particularly with the reduction of time between the first, if you like, examination where we have bad results, meaning the first low-dose CT or first X-ray, and we're talking about the biopsy. So we want only 1 month between these two tests, meaning low-dose CD or a chest X-ray and biopsy. We don't want a long time to go by before the histology. And this is a very important goal. We want to help in order not to reach stage 3 and stage 4. What we want is to find the cancer patients early when they are in stage 1 or 2. Thank you very much, Mrs. Saridaki. We will come back with questions from the audience. Now let me move on to Mr. Zervas. He's a pulmonologist. He's from the Sotiria Hospital, and he's also the General Secretary of the Greek Respiratory Society.
So, from what we heard, you've been working together with the ministry and the Hellenic Respiratory Society regarding this program. So let us know a few things as to where it currently stands and how it contributes to this, how the Respiratory Society contributes to its growth and development. Good morning, everyone. Thank you very much for the invitation. The Hellenic Respiratory Society, as you know, is highly sensitive to such issues, together with the smoking issue. We are side by side with the patients from the early phase of diagnosis, the treatment, the end-of-life care, etc. So we take this journey together with our patients, and what we want, and this is a huge effort undertaken by our society in this past year with this Breath of Life, with the support of Johnson & Johnson, the promotion of screening and early diagnosis of lung cancer. Well, we agree with whatever has been said. All these programs have a point and meaning if planned centrally and if they are generally available and accessible. In cooperation with the ministry, we are trying to do what the UK has done so far. We launch pilot projects in several hospitals, such as the Soteria Hospital, the Papageorgiou Hospital in Thessaloniki, or other hospitals around the country and in Crete, etc., to run some pilot local programs with a screening test, as is the case with Metropolitan Hospital. This will allow us to further expand this program. The whole value of early screening and the use of low-dose CT has a point if it's done on a national basis, because we know, following the trial, etc., we know that we will achieve this high value. The only thing that is pending is for us to implement it, and we hope that we will be able to do that. So I'd like to say that we are in cooperation with the Hellenic Radiation Therapy Society and the Hellenic Cancer Federation to draft specific guidelines on lung cancer, so that we can all speak the same language and be able to implement these programs in practice. Thank you very much, Mr. Zervas, for this, for saving us some time. Of course, we'll come back to questions afterwards, because we've already received a question addressed to you by the audience. Now, Mr. Leonis, whatever we've been hearing is quite significant. However, we need to come in contact with the general public, be them smokers or not, from the primary healthcare level. So we need to communicate with them to let them know about the next steps to follow. So this is an important part. Mr. Leonis, we're all ears. Thank you very much, Ms. Kapsi. Congratulations to all organizers for this excellent initiative. Allow me to point out that in Greece, many things are going on, and we have excellent aspects. We have people who have contributed to the development of knowledge. However, there have been no coordinated efforts. Ms. Saridaki so eloquently put it. We have no coordination, neither on an institutional level nor at any level. This initiative, I hope, is towards this correct direction. Now, I'd like to speak about the way we could contribute to this effort. And I hope that Ms. Kapsi, we would really be able to contribute and meet. Because if we rest on our laurels following this day, then this whole effort will be to no avail. So I'd like to ask you to meet and form a working group that will gather and collect all these experiences and submit them in the form of a position paper to the minister to see to what extent we can implement all this effort. I'm talking on behalf of the Clinic of Social and Family Medicine at the University of Crete. We emphasize prevention, but we've been talking about prevention in Greece for the past few years. Unfortunately, there has been no implementation. Why is that? Because the people, human resources, have not been trained as to how they will be approaching citizens. We are talking about specific identities. We need to have a risk perception and literacy, health literacy. So the truth is that since I can talk about Crete, so where I live and teach, we address ourselves differently to citizens who live and develop their own culture, to the mountainous areas of Peloponnese and of Souliotis and the White Mountains, and differently to people residing in urban areas. The risk perception seems to be a significant factor together with literacy. So there can be no change in behavior without training human resources, particularly health professionals, who need to go closer to the citizens, to the patients, to their family members, bearing in mind their own proper identity characteristics, using special techniques, and I refer particularly to the motivational interview, which unfortunately is not taught in the schools of medicine. So we need to retrain health professionals, particularly primary health professionals. We at the University of Crete have already developed educational material using such theoretical approaches, behavioral changes on the basis of the risk perception and literacy. And in this way, we have already published the results from the training of a large number of healthcare professionals, GPs, as well as primary healthcare professionals. In cooperation with the National Health Services, we have in fact developed certain techniques. I've sent you a recent paper regarding the provision of advice. So healthcare professionals could follow such techniques, not only pertaining to smoking cessation, but also behavioral changes. We've also developed educational material. I think that Ms. Leonardo also touched upon it regarding second-hand smoking. We are talking about educational material to educate primary healthcare professionals. Alas, you know that the Hellenic Respiratory Society has done a lot of things, and it has greatly contributed to smoking cessation programs in hospitals. However, I refer to the retraining of human resources working in primary care. Here we need to achieve synergies and take advantage of programs developed by universities and societies. Or this could be actually combined and form a specific proposal that will lead to the change of this behavior and to lead to smoking cessation. To conclude now, we've been talking about prevention. Prevention does not necessarily mean that we address ourselves only to health professionals, therefore we need retraining. Of course, through this retraining, they will have an effect on citizens, patients, and their family members. In fact, prevention programs and behavioral change programs cannot go ahead without the participation of the stakeholders themselves. The truth is that we keep them apart and we use them only to support our own choices. Active participation of people, of the agencies, of the community, either in the form of local government organizations or even other agencies acting therein. Active participation with the participatory learning action. I'm talking about an open democratic dialogue procedure that at a local level would work in order to raise awareness. And last thing, we talked about early diagnosis. It is important, yes, in Greece, we need to start implementing things. We need to also have research and study in Scandinavian countries. In Norway, a few years ago, we saw the early diagnosis of cancer in general practice book, which would follow models where they identified the probability a priori. And we know Bayes' theorem when we know the incidence of a symptom or of a sign in an area, together with the prevalence of cancer. This allows us to easily run a diagnosis. Such type of algorithms on the basis of studies that will have sought the expression of the symptom, as Mr. Zanetos put it, cannot be translated into decisions by the doctors. So we need to run a research on symptoms, particularly in primary healthcare and GPs. We need to identify probability rates and indicators in all the signs and symptoms pertaining to lung cancer. So concluding, I'd say that all these actions in primary healthcare, aiming at training human resources, using whatever material we have at hand, from companies, from societies, from universities, etc., with parallel reference and inclusion of the organizations and agencies of the local government, and in combination with a serious research, will help us achieve what we want to achieve. Thank you.
Thank you very much, Mr. Leonis. You mentioned a lot of things, a lot of important things. I don't want to leave your proposal without an answer, even though I haven't talked to the FairLife board. But I'm certain that what you said, that we should get together, of course, this will materialize, because a factor of success of FairLife from its very outset is that all the stakeholders were put around the table: society, the community, local government, scientific groups, from day one. And this is why FairLife has progressed so much. This is why it has moved so fast, and why it's had so many actions, and why there is such a big acceptance. Thank you very much. Now let us move on to Mr. Foroulis. Mr. Forouli, the role of thoracic surgeons when somebody is diagnosed with lung cancer is very important. And if this is done in a timely fashion, it's very important to have many treatments. And of course, we have the contribution of robotics and other techniques. And we see that There are miracles taking place. So what's happening now when we have timely diagnosis? What is your role, and what is the role of the group that you represent, the Hellenic Society of Thoracic and Cardiovascular Surgeons? I would like to make a brief introduction. Since we're speaking of prevention today, what is important is not to have new smokers. We don't want more people smoking. So we're now talking about former smokers. So we want the former smokers to be able to enter into a screening program. So for former smokers, things are simple. For the current smokers, well, there a lot of effort has to be made. We have to persuade them to enter this screening program. Why? Because it's a matter of mindset, the mindset of smokers. We know what that is, meaning because they're smoking, they don't want to think of problems that may be caused by smoking and their smoking habit. So as thoracic surgeons, we have understood for many years now and quite well the value of investigating the small shadows that show up in the CT scan, in the chest CT scan, and which one will also see them showing up in low-dose CAT scans. And we are in favor of monitoring quickly. We don't want for a shadow to become bigger and bigger and bigger. We can't wait, because now we know very well that a small increase in size has a big impact on survival. And when we're talking about early stage carcinomas, if I want to carry out a radical treatment, we have to be careful, because if we go from 90 to 1 point something, then it's terrible, because the survival goes down, meaning going from 1.2 to 1.3 and so on and so forth. So we work together with other societies dealing with lung cancers. We work together with the Hellenic Respiratory Society. We're talking about their guidelines. We've participated. We have our own input in their guidelines. And what is very important is that once a lesion in the lung is discovered, and it could be the lesions in the form also of a compact mass or a combination of the two, meaning we can use, we can see various combinations of different lesions, but these lesions have to be removed. They have to be sent for biopsy, for histology, and if it turns out to be cancer, then we might need to have an extra excision. So our role is very important. Now we have thoracoscopy, and we can identify these lesions and remove them without sacrificing a lot of lung parenchyma, at least in the initial phase. But I have to stress here that there are other problems as well. For example, localizing the lesion, particularly when it's deep inside the lung. And another very important matter is to remove this lesion radically, because these biopsies for which there is reference by some speaker, we're talking about UBOS, for example, and other biopsies. In these initial lesions, there can be infiltrating and non-infiltrating elements. So by removing the entire lesion and looking at it under the microscope is more important than just getting a small biopsy, which will prove that there is no infiltrating element, because this may not be true if it's not the entire lesion. I don't want to take up too much of your time. We have an important role to play in all of this. Why am I saying this? We know that people who have survived after a successful surgery, there's a large percentage, 10 to 20%, of developing a second primary cancer, which will begin as small. So we have to monitor these patients for 10 years, because with a second surgery, we will be able to save these patients for a second time. Finally, I would like to conclude by saying that soon we have to create the algorithms, meaning which patients are the ones who will enter these programs, and how will we identify them in the general population, and how will we then persuade them, because this requires a lot of effort, and we need to have the help of the scientific societies, of the radiologists, the pulmonologists, and other associations, FairLife and other organizations that are active or will be active in the area of lung cancer and management thereof, so that we can all convince these people that screening is very important. It's as equally important as having a program, because if you have a program in place and the people who should participate are not convinced and are not participating, well, I think this will mean that the program will not succeed in the end. Thank you very much. That's all I had to say. Thank you for inviting me.
Moving on to Mr. Vernaraki in the area of interventional radiology. We're talking about screening with low-dose CT. However, do we have such equipment in Greek hospitals available? And if we do, is there a respective software to help us process the results? What is required for this kind of screening to function? Good afternoon. I'd like to thank you for the invitation, and I'd like to congratulate you for your excellent initiative and event organization today. Now, as a radiology society, interventional radiology society, we know that in the overwhelming majority, the laboratories of the hospitals around the country do have the necessary equipment, which is none other than multi-slice CT scanners of a specific technology and above, with specific properties which fulfill the criteria for a low-dose CT. Definitely, there are different classifications of the equipment in the hospitals of our country. However, we need to point out that the overwhelming majority of our CT equipment is able to respond to the demands of a screening program for lung cancer, which has as a main tool an imaging examination, which is a low-dose CT. Now, regarding the software that you have mentioned, by definition, the multi-slice CT, particularly regarding the low-dose CT, call for analysis of the slices, particular PCs and computers with the respective software that will allow for the proper evaluation and assessment of the findings. I don't know if you can hear me, because there have been some technical issues. So the more modern is the technology of the CT scanners, the easier it is to incorporate specific software which will allow us to identify and properly classify the findings. When the software, this specific software is available, we recommend strongly the use. However, if they are not available, we cannot achieve a reliable evaluation. Now, with regard to the requirements, definitely we need the medical devices, which we said are available in the overwhelming majority of hospitals and private centers in the country. I'm talking about equipment able to achieve appropriate low-dose imaging tests. We need to have a continuous training and information of doctors on that subject, making sure that there are protocols in place for such tests and examinations. And another thing, it is also important to have a cooperation between the radiologist and the rest of the medical specialties. We need to be working as an interdisciplinary team, aiming at ensuring the highest possible benefit for our patients. The Hellenic Radiology Society, recognizing the significance of our specialty in such screening programs, using as a main tool an imaging examination, which is the low-dose CT, absolutely supports and fervently supports such initiatives and actions, and is in close cooperation with other scientific societies, particularly the Hellenic Respiratory Society, Thoracic Society, and we work together as a team, having as an objective the establishment of the proper foundations for screening programs for lung cancer with the use of low-dose CT. Unfortunately, there is a poor connection. We can't hear the speaker. Ensuring low radiation and proper evaluation of findings and results on the basis of algorithms, always in cooperation with the rest of the specialties. Thank you. Thank you, Ms. Tavernaraki. Now we move on to Mr. Pisakas, radiation oncologist. Mr. Pisakas, usually you are the one who presents the issues on the table, and I'm asking you, what are the obstacles for the implementation of screening in our country? What can be done? At this stage, I'm really lucky because being the last speaker, everything has already been mentioned in our own specialty. We usually come to see the most advanced stages.
So we're talking about participation in prevention. This is through other societies, and we want to be by their side. And we also saw this wonderful diagram showed by Mrs. Linardo. We see that in the early stages, things are very important. So first we have surgery, but if we cannot operate, then we have radiation surgery. It's a type of radiation treatment which in very early stages can have equivalent results to surgery. So the proposals by Mrs. Linardo are correct. That's what we intend to do. So I will take some time to comment some things that were mentioned. First of all, everybody must listen to what Mr. Tsimaras mentioned, Mr. Tsimaras Zanetos, because we have to listen to people like Mr. Zanetos. When they say that there's something wrong, we have to help them find what's wrong. And Mrs. Hatziandreou quite rightly mentioned, we're talking about a cancer that is a killer. Lung cancer kills people. So let's say that we have a field and we want to clear it of the weeds. The first thing is whether we can avoid the weeds growing there. But if we have killer weeds growing, then we must eradicate them as quickly as possible. So this is the most important thing. And we heard Mrs. Linardo and Mr. Souliotis. They all said that we're talking about 3,500 people who could have been saved. And it's not just that we will save these people. It's just that lung cancer must be prevented at early stages. So we have the weapons, but sometimes instead of using this opportunity, we let it go to waste. We have to intervene in a timely manner, and this is very important. This is why it's important to have early diagnosis, timely diagnosis. It helps save lives, and it also offers quality of life. So you can avoid things, and that's the important thing. So I think we need to do this in an organized fashion, and we must never forget it. Lung cancer is a killer. So this is lung cancer gives us a lot of deaths. So we have to find better ways to save people. We have to be able to prevent it. There's nothing else I'd like to add. I think everything else has been mentioned by the previous speakers. Thank you very much, Mr. Pisakas. We have quite a few questions from the audience. So let me say at this point that some of the questions may not be answered here, but the answers will be provided on the site of FairLife. So no answer will remain unanswered. Two questions to Mrs. Linardu. I'd like to condense the questions. There is an anxiety, a stress expressed by the people regarding the vaccine, COVID-19 vaccination and lung cancer screening. So that's one thing that they worried about. Now, another thing, Mrs. Linardu, lung cancer, is it only for people who smoke, or is there also a hereditary element in all of this? Now, let me talk to you about the vaccine, the COVID vaccine. Of course, in the instructions by AOV and all the international guidelines, people suffering from cancer belong to vulnerable groups. So they are the people who run a higher risk than many other people. So they are in the front line, and they must be amongst the first to be vaccinated. So beyond the shadow of a doubt, go get vaccinated. Now, regarding the third dose, the booster dose, the vulnerable groups were prioritized for the third dose, the booster dose. So if you already had two doses, and I'm referring to cancer patients, they must also go for the third dose, of course, after discussing it with a doctor. Now, heredity and whether lung cancer is only for smokers, whether it affects only smokers or whether there's a heredity involved. So I'd like to say smoking is responsible for 80% or over 80% of lung cancer cases, but there's also a percentage that is not due to smoking. And among other factors, for example, air pollution, exposure in the workplace, and so on and so forth. There's also a small percentage that is not due to any of these factors. We know that there's some subgroups of patients that express some specific molecular mutations or changes, and these are found in non-smokers, and we're talking about specific histological types, and these are the subgroups that we find with thorough or comprehensive molecular screening. So is lung cancer hereditary? It's not one of the traditional types linked to heredity, but there's a lot of research on this field in the last few years, which shows us that there may be familial cases, so there may be some cases of heredity. For example, you might have a father and siblings or father and children. So there are various models to estimate the risk, and we're talking about participation in screening. So family history is also included. So if there's a family history of lung cancer, this is one of the criteria that can be taken into account regardless of smoking habit. And in this case, screening may be recommended to an individual. I hope I answered the questions. Absolutely, and I think your answer was pretty clear.
We just got a question for Mr. Souliotis. Given that this is an expensive test, how is there going to be a rational management of resources in a country with such a bad past? Well, expensive or cheap is something very relative. It's much more expensive to calculate the cost of treatment at a later stage. It's not that expensive, and if we were to use it as a global like a universal screening, then the cost would be manageable. Now, I don't think that it is prohibitive as compared to the financial status of the national health system in general, if I may. Prevention calls for front-loaded funding or financing. In the mid-run and in the long run, you will see the benefit, but you need to do it if you are to see a benefit. Now, quite correct. A question for Ms. Leonardo. What will happen with the bioindicators, biomarkers? Will they be reimbursed at some point? Yes, it's a general question, of course. It's always topical. Quite a few biomarkers are being reimbursed in the country following the efforts of the organizations and agencies involved. However, there's still room for improvement, and what we are going after in lung cancer, all scientific societies want to have a reimbursement for the inclusive screening. Talks about the entire molecular identity of lung cancer. Therefore, our society is a pioneer in this effort. I think it's worth referring to that. Yes. We have the same question for you, Ms. Saridaki. Would you like to add to that? Yes. What Mr. Leonardo said is indeed true. Together with the other societies of oncology, the radiology society, we've been trying for years to include biomarkers in the reimbursement scheme. As of 2013, there has been no updates and upgrades. It has no point. There's no point in introducing isolated biomarkers, but rather to have reimbursement of entire biomarker panels for many cancers, one of which should be lung cancer. And there is an effort to have the NGS reimbursement. We hold discussions with the negotiations committee, and we hope that it's going to be a reality soon. How soon? Yesterday would be good for me, but we hope that it won't be next year. It will be earlier than that. May I add, yes, another remark? Yes, Mr. Pisagas. This is one part, one aspect of the issue. Considering where delays actually take place, you'll see that the whole problem is when we have an histopathology report, when we have the diagnosis. Prevention is quite good, but the earlier we get it, the better. So we don't want to be losing time until we have an histopathology report. This part has to be definitely improved. It pertains to all types of cancer, but in particular lung cancer. This is something we need. We shouldn't lose time in these very small steps until we get access to treatment. This has to be shortened. Thank you for the intervention. We don't have much time. We have two more questions. One for Mr. Zervas. Mr. Zervas, if lung cancer can be easily diagnosed following an X-ray, chest X-ray, which is usually done for another reason, and we have a random finding, why don't we introduce this simple examination in the annual screening? Unfortunately, chest X-ray is not the most appropriate means to diagnose lung cancer. Studies in the US have shown that if you are to diagnose lung cancer, you need to have low-dose CT. As compared to X-ray, chest X-ray, it has very good results. Therefore, the chest X-ray is a tool we used to have in our armamentarium 20 or 30 years ago, but nowadays we cannot still talk about the X-ray as a tool. So the answer is not annual X-ray. There's no point in it. There is point in low-dose CT to target a group of people. We should not give it for all smokers. I'm talking about high-risk patients. Thank you. Thank you very much. And one last question for Mr. Tavernarakis. I think it has already been answered within this discussion, but if you insist, we will repeat it. Are there significant findings that can be identified through a low-dose CT? Definitely. There are other random findings that are clinically significant, such as other lung diseases, such as COPD or interstitial lung diseases, cardiovascular diseases, or even masses at other organs. So all these render more attractive this specific kind of screening test. Thank you very much, Mr. Vernaraki. We thank you all for your participation. There is no more time for further questions, so we will reply through the FairLife site. So we close this session and we move on to the next session. Before we do so, however, I'd like us to watch a brief video on the action Learn, Act and Hope. This is addressed to all those who want to acquire scientifically documented knowledge. In this action, we have the participation of distinguished guests. So no one is left on their own. Thank you.
So we're talking about Learn, Act, Hope. It's aimed at prevention, but also acquiring knowledge about every stage of lung cancer that a patient goes through. Over 70 scientists from Greece and abroad answer all the questions that concern patients and their loved ones. We inform, we prevent, and support with the generous support of pharmaceutical companies. It creates a new source of knowledge. I learn, I act, and I hope. May life take your breath away and not lung cancer. Get informed now. FairLife is here for you. Thank you very much, Nelly, for the baton, and let us continue with the pharmaceutical companies, beginning with Mr. Christos Analoglo, MD, PhD, Head of Oncology, Hematology, and a member of the Board of AstraZeneca Greece. Mr. Antonopoulos, welcome. Thank you very much, Mrs. Papadimitriou. I would also like to bid good afternoon to the audience. It's a great honor to be amongst such distinguished speakers, and we have a commitment. All of us have undertaken a commitment so that what we heard today about lung cancer may become in the future a reality. We want to be able to say in the future that we beat cancer. I think we have the weapons in our arsenal. Let me move on to the next slide. In the last decade or 15 years, we have had a revolution in oncology. So there have been great strides in research and development by pharmaceutical companies, but also from the academic community as well, particularly in the field of cancer. We have seen that now, together with scientific research, so we have the new treatments, at the same time, more emphasis is placed on the patient. So everything is more patient-centered. So look at the patient experience now. The pharma, meaning the pharmaceutical companies, seriously take into consideration the patient experience. And this should have always been part of the equation when we're talking about the new data in cancer and particularly lung cancer. So let us move on to the next slide now. So we're putting patients at the heart of what we do. So we're talking about precision, if you like, medicine, and so on and so forth. So now we have discovered in every minute detail the journey of the patient, and we have gone away from the view that we only see the patient during treatment. And as was mentioned by the previous speaker, we start from awareness, prevention, diagnosis, and also after treatment, we have post-treatment and wellness. So it's a long journey, and I think that everybody involved in the patient's journey should contribute. And I think that artificial intelligence now gives us this possibility. So the pharma industry is there by the side of the patient. And as I told Mrs. Patelli, we are walking together along the patient's path in order to achieve the maximum benefits. Let's move on to the next slide. This was mentioned many times over. It has been mentioned by many that the COVID pandemic has had a negative impact on diagnosis of other diseases, even lung cancer. So I think we need to do our part. And we, as the pharma industry, have supported the ELOC campaign, awareness campaign. ELOC is the Hellenic Cancer Federation. So habits may have changed, but cancer hasn't. So you see the data today showed us that early diagnosis may even mean full cure. Let's move on to the next slide. In June, beginning of the summer, we had a press conference. We had the participation of distinguished speakers, some of whom are participating in this conference today. So we launched this Do Not Wait, Min Perimenis. It's an awareness campaign for the general public, and it's focused on exactly what you're talking about. So we're talking about providing information, raising awareness, and prompting those in the high-risk group, meaning active smokers above the age of 50, to go for screening, screening for lung cancer. And I would like to talk about Mrs. Linardo's data. So if we diagnose cancer at an early stage, stage 1, there's a 92% possibility of curing the patient from cancer. That's a very high percentage. And it's a shame for us not to do this since we have the opportunity and the infrastructure. We also heard today quite a few times the word of alliance and collaboration, and also involving all stakeholders. So the Lung Ambition Alliance is a global initiative which may have started thanks to AstraZeneca, but it includes all the stakeholders, all the partners, and in the next session, the head, Fred, and colleague, Kyriakos will offer more information, but I would like to say that in order for us to be able to achieve what we have set as a goal, what is needed is collaboration of all of us, and also participation of all associations and societies. And I heard very carefully to Mr. Dimopoulos and Mrs. Gaga this morning saying earlier that the state will help in this direction. Next slide, please. Finally, what is an obstacle in lung cancer management is the taboo, the fear that exists, the fear of, well, you don't want to be the person with such a problem. So this is a taboo, and this actually doesn't help in early diagnosis. So we saw that Simon was a source of inspiration, and people like Simon made us try to create an infographic which will explain in a different way why we must have early diagnosis and why everybody should accept lung cancer, and they must understand that lung cancer can be cured. Let's watch this infographic. So learn through my story what the patient and the family go through. Name Luca, age 57. Luca, unfortunately, I've got bad news. Based on your test results, I believe you suffer from lung cancer. I hope I have something very important to tell you. There was some significant findings in my tests, and we have to deal with lung cancer. We have to fight together to beat lung cancer. Luca, your diagnosis is non-small cell lung cancer. Okay, this doesn't mean that your dad will die. We love you very much, Dad. So my experience combating lung cancer, it's important to follow the guidelines. You have to trust your treating physician and the multidisciplinary team and so on and so forth. FairLife. So I would like to tell you in this next slide that if we all act together and if we all try as partners to commit to what we are saying today, i.e. we must commit ourselves that it won't be lung cancer that will take our breath away, it will be life that will take our breath away, and we're really proud as AstraZeneca to be contributing to this effort that is being undertaken by FairLife, but also by all the other societies and stakeholders. I also want to join my voice to Mr. Souliotis' voice and Mrs. Leonardo, and as an infection specialist, to urge those of you who have not been vaccinated, speak to your doctor, think about it, and go get vaccinated. Thank you very much, Mr. Antonopoulos.
Well, our message to take home is the fact that you described an alliance which is really significant, really strong, and it changes how the things will turn. Now I'd like to call upon Mr. Kyriakos Souliotis, MD, Chief Medical Value Officer from Roche Hellas. Welcome, Mr. Souliotis. You have the floor. Good afternoon. I'd like to warmly thank you for the invitation, and I'd like to congratulate you for this excellent event that you've been organizing today with the significant messages that have been conveyed by the previous speakers. From my point of view, in the past 15 years, we've been working on lung cancer, either in research and development by offering treatment and therapeutic and diagnostic tools in order to help doctors and patients deal with their disease. Now, in our third transparency, this is done on the basis of an individualized approach. We need to adopt this individualized approach. The appropriate patient to be given the appropriate treatment at the right moment. Regarding the appropriate patient, I'd like to join forces here with Ms. Ridaki, who said that we need to have the appropriate biomarkers and we need to move towards us having a complete molecular screening of our lung cancer patients if we are to administer the proper treatment. Regarding the proper time, well, the earlier the better. Let's move on to the next transparency. I'd like to emphasize here something that might have already been mentioned. Lung cancer, and this is why we have focused so many years as a company on lung cancer in treatment and in diagnostic tools, but it is important disease. We have so many million of people. The cost for the US, you can see, is really high, 13.4 billion per year. I think that we can do much more than that. And when I say much more, we need to intervene earlier. If we want to be efficient and effective, we need to move earlier. Obviously, there are excellent tools in the metastatic stage as well, but we need to move early. And a significant effort here is early diagnosis with the tools that we have in hand, with the low-dose CT. At the same time, we have the diagnosis part with biomarkers treatments at the early stages of the disease, targeted treatment, immunotherapies at early stages, because as you can see here, Mr. Radonopoulos also mentioned it, the earlier, the higher the survival. In metastatic stage, we have a 5 to 10% survival rate. However, in an early stage, we might even reach 90% survival rates, and treatments may increase survival at the early stage as well. Here, regarding early detection, an important tool for that is CT scan, the low-dose CT scan. Now, I'm glad to see that there has been a local study which reproduces, in fact, the findings of other larger studies, the Nelson, the NLST study, etc., showing that we can reduce mortality by 25 to 30% if we have an early diagnosis. This is significant, but we need to have this early diagnosis in a targeted way, and those patients of high risk should be given the opportunity to undergo a low-dose CT, because as Mr. Souliotis said, only 3 to 4% will be random findings. We should not rely on luck. Through a program, we need to give access to high-risk patients to low-dose CT at regular intervals. Next, transparency. And I will conclude saying that as of 2019, Roche has been running a campaign of raising awareness on lung cancer. 2021, 2022, it will focus on early diagnosis with the participation of many health professionals, patients, societies, aiming at joining forces and voicing together our concerns, bringing cancer at an earlier stage of diagnosis. I want to conclude by repeating what Mr. Linardo said. Every centimetre counts, so we need to bear this in mind and join forces to achieve early diagnosis and prevention. Thank you very much.
Thank you very much, Mr. Koulouris. And before welcoming Mr. Bouki, who is the next speaker, I would like to inform you that we also had invited Mr. Nikolaos Hatziandreou from Pfizer, Greece, Cyprus, and Malta, but there was a problem for him to connect, and unfortunately he won't be with us. So before Mr. Bouki, we will have a video from Amgen Elas. Thank you. For 40 years now in Amgen, we are at the service of our patients. We push science to the limits in search of treatment of serious diseases. By discovering solutions every day, we can transform the lives of patients. In Amgen, we build the future of biotechnology by linking the lines between biology and man, Amgen. Mr. Christos Boukis, Value Access and Policy Lead of Amgen Elas, is with us. You have the floor, Mr. Boukis. Welcome. We can't hear Mr. Boukis. I'm very sorry. Please switch on your microphone. Unmute, because you're muted. We can't hear you. Quite right. Thank you. Thank you very much. It's a pleasure for me to be here and to be able to support the activities of FairLife in relation to prevention and prognosis of lung cancer. So, by way of introduction, you won't hear a lot of new things from me. I was very lucky because what I was going to say has already been mentioned by many other speakers. So anyway, it doesn't matter. Repetition is the mother of learning. So you will hear it from me again. So first slide. Let us say that, as mentioned by previous speaker, lung cancer is a scourge. Let's move on to the next slide. Yes. So, as I said, lung cancer is a scourge in the sense that, 25% of deaths, as Mrs. Hatziandreou said, 25% of deaths is due to lung cancer, is due to cancer, and 5% thereof is lung cancer. So we see that there's a large percentage that is not linked to the incidence of the disease, but to the mortality that it causes and the burden that it causes to patients. So let me mention that, as was mentioned by previous speakers, 90% of patients that are diagnosed at a late stage will die of lung cancer. Unfortunately, this means that the patients' lives are destroyed, but also the lives of their loved ones, and it's also a big burden on the healthcare system. According to 2013, the cost for the Greek healthcare service was €18,000 per patient per annum, the cost of hospitalization of treatment. Now, according to the latest data, according to the OECD of 34 countries, the cost in Europe, as mentioned by Mr. Souliotis, is €100 billion per annum. So we're talking about huge figures. And this has an impact on healthcare systems, but it also makes the treatment of lung cancer difficult, but it also makes it imperative to deal with lung cancer in an efficient manner. So the pharma industry and many companies have set as their priority personalized medicine, the main aim being to identify specific patients who will be given targeted drugs at the right moment. So the timing is important. And as was mentioned by the previous speaker, this should be done as soon as possible. So that's what we need to focus on. And in personalized medicine, which is not enough, though, by itself, without early diagnosis, timely diagnosis. And now let's move on to the next slide now. So what we can say here is that the industry has actually done its utmost in order to use new technologies, digital technologies, in order to be able to identify the right patients at the right time. There are different collaborations between farmers, national associations, in order for them to use AI technology to identify the right patients at the right time. So let's move on to the next slide. This happens at a European level, but in Greece, we're not lagging behind. So in Greece, we're lucky, we're fortunate. We have a healthcare system which is based on data, it's supported by data, and the prescription data cover 98.5% of the population. We have some registries. Some are not complete, others are. We have diagnostics. We have personal e-health records that are now underway. So this is very good. And we have inpatient data in every hospital. And sometimes there is no linkage between these, no interconnectivity, but these soon will be connected. And this is a very useful tool in order for us to be able to recognize the patients who have a high risk of developing lung cancer. So using all this information together with new technologies, and as you can see from the next slide, we're not lagging behind as a country in all of this, because these are technologies because we talked about what COVID actually gave us, what it made us do differently. So Greece used AI to curb COVID. So we know at the gateways of the country which people are more likely to have COVID, and they're the ones that are subject to testing. So this is AI. It's a very good initiative that is now being implemented. So we're talking about AI that is now being applied. So we're trying to see whether this is something that we could also use in the prevention and early diagnosis of lung cancer. I think if we do this, this will be good not only for the patients, but also for the healthcare system as a whole. But we have to take a step further. So even that is not enough. Why is it not enough? Because it's not just good enough to treat a disease when you find it. You have to try and find it early. So the first step that we must make as a country, as Greece, is in the context of the prevention program Spiros Doxiadis, it's good to include screening for lung cancer in this program as well. So let me move on to the next slide now. This is my last slide. We believe that in order for us to be able to deal with lung cancer in an efficient manner, in order for us to have a winning position in the coming years, what we need to do is to focus on prevention. We have to look at the risk factors, and we need to reduce smoking. There are all these campaigns, anti-smoking campaigns, anti-tobacco campaigns, like the ones that we see in the UK, where they show what people stand to lose if they smoke. And we can also use AI and technology, new technology, in order to identify high-risk patients. And finally, for people who are ill, who suffer, we can use new biomarkers and early NGS testing in order to find the right medicine for the right patient at the right time. So by way of conclusion, let me say that, I'd like to go to the next slide. This is not sci-fi, it's not science fiction. This can be done, it can be done immediately. We have the resources as a country, and we will be very happy to contribute so that this can become a reality. Thank you very much, Mr. Bouki, for your intervention.
So this concludes this session, and before I give the floor to Nelly Kapsi once again to moderate the conclusions section, I'd like to say that it has been an honor for me to moderate and coordinate this important scientific discussion, and I need to point out what my conclusions have been from the journalist's point of view. By definition, I am an optimist, but I have documentation to base this optimism on. So as we speak, we have alliances, we have data, we have evidence, we have documentation, we have tools that have been developed in the past 2 years. We have ideas, we have scientists, plus we have the correct timing with the Ministry for Health, Ms. Gaga, knowing very well how things work, and all this will help us speed up the processes. I'd like to keep in my mind the number of persons who will be saved with the use of screening. This screening can start as of tomorrow, and this will allow us to take an important step to make FairLife's message come true. Let life take your breath away, not lung cancer. Thank you very much. I give the floor to Nelly.
Give up now, but not for us. Impossible inspires us to give everything, to try harder. Impossible tells us there's more to know, more to explore, to use science to change people's lives for the better. With mRNA technology, we're making a new generation of vaccines possible. Thanks to remyelinating therapies, rebuilding damaged nerves is now possible. And by developing groundbreaking gene therapies, we're making treating rare disease possible. But we're not stopping there. With over 8,000 new medicines and vaccines in development, together, we're making the impossible possible.
So we can now move to the next session pertaining to the patients, coalitions and associations from Europe and Greece.
Cancer prevention, screening, and early detection. I'm Carolyn Aldeget, the founder and CEO of the Prevent Cancer Foundation, located just outside Washington, D.C. but I also have the honor of serving as vice chair of the Global Lung Cancer Coalition, an organization comprised of over 30 NGOs from more than 30 countries. And we were delighted to recently welcome FairLife into the coalition. We all know that up to 50% of cancer cases are preventable, and about 50% of deaths from cancer are preventable. Yet every year in this country, 1.8 million Americans are diagnosed with cancer, and more than 600,000 people will die from these diseases every year. Imagine if all cancers could be prevented or detected early enough to be successfully treated. We do imagine, we dare to imagine a world without cancer. We all know that lung cancer is the leading cancer killer globally. Annual deaths from lung cancer globally are 1.8 million, which is 18% of the total mortality from lung cancer in the world. In the US, that number is 132,000 annually, and in Greece, it's just over 7,500. But that's enough to make Greece rank as the country with the 11th highest mortality rate from cancer. Lung cancer has been transformed from a rare disease to the leading cause of cancer incidence and mortality worldwide. So how can this alarming statistic be reversed? Well, of course, we all know that if everybody stopped using tobacco products tomorrow, that would reverse the alarming statistic. But because we all know that that's not likely to happen, we have screening with low-dose CT. And that's how we help solve this lung cancer burden. We screen those who are at high risk with low-dose CT. I'll share with you a timeline for lung cancer screening in the United States. It was quite a lengthy process to develop a national lung screening program. In 2002, the National Lung Screening Trial was activated at a cost of $250 million with over 50,000 participants who were randomized to either LDCT or chest X-ray. In 2010, the trial reached its primary endpoint of a 20% reduction in mortality and was halted. In December 13, the cost began to be covered by private insurance, and 14 months later, in February of 2015, the cost began to be covered by government insurance. So I'd like to pose the question, how does the Prevent Cancer Foundation work to advance LDCT screening in the United States? We hold a signature conference every year, a quantitative imaging workshop, which is a forum that advances quantitative LDCT screening for education and management of early thoracic disease, not only lung cancer, but also COPD and cardiovascular disease, which can be detected in the same set of images as lung cancer. And these are 3 of the 4 leading causes of cancer death in the US. We also work on screening in the community. And about 2 years ago, we made a grant to a small county in northern Michigan. A grant of $25,000 enabled the McLaren County, Michigan Hospital to educate patients about lung cancer signs and symptoms and to screen 16,000 individuals at high risk of developing lung cancer. Well, you might well ask, who is at risk of developing lung cancer? In the US, that is defined as individuals who are 50 years of age or older, are current smokers with a 25-pack-year history of smoking or use of other tobacco products, and are former smokers who quit no more than 25 years earlier. We also give voice to early detection. We influence public policy at all levels. We cultivate grassroots advocates, and we connect with other national cancer organizations. Our priorities are to increase funding for lung cancer and screening research. We work to reduce health disparities, and we support legislation that improves access to screening and care. Yes, we dare to imagine a world where no one dies of lung cancer. Do you? Thank you very much for your attention.
Thank you very much, Carolyn Boe-Aldrich from the Global Lung Cancer Coalition and founder and CEO Prevent Cancer Foundation. I'd like to remind you that this was a recorded message. Now let's move on to Caius Kim, a Global Director of Lung Ambition Alliance. Mr. Kim, we're very happy and honored that you're with us.
Yes, thank you so much for this opportunity. I think great, thank you.
Could you tell us more about the Lung Ambition Alliance and what can help in the prevention and therapeutic of lung cancer?
Yes, I'm very proud to be able to present the work that we're doing as part of the Lung Ambition Alliance. I believe my first slide is up. As you can see here, the Lung Ambition Alliance is an innovative partnership amongst 4 organizations, which includes some people that have already spoken at this meeting. So Heather Wakely, who is the president of the International Association for the Study of Lung Cancer, or ISLAC. We have GLCC, which is the Global Lung Cancer Coalition, which is a broad group of patient advocacy groups from around the world, Guardant Health, as well as AstraZeneca. And the 4 of us, we've come together to advance outcomes in lung cancer. And we have a very ambitious goal in that we want to double survival by 2025 in every country around the world. If I might ask for the next slide, please. We're aware that lung cancer is different and that the situation in the US is very different than the situation in Greece, as well as a situation in the Philippines, as an example. Here you see that around the world, outcomes in lung cancer differ country by country. Japan leads the world in outcomes in lung cancer. And this is because Japan leads the world in diagnosing people with lung cancer at an early stage. You can see correspondingly the decrease in outcomes around the world from Japan all the way down through Italy and France, the UK, Thailand, Brazil, all the way down. So there are opportunities to be able to improve outcomes at every country. And this is the underlying philosophy of the Lung Ambition Alliance, which I will speak to. Next slide, please. How will Lung Ambition improve outcomes by 2025? We have 3 main areas of focus. One is the focus of this meeting, which is early diagnosis. We have other aspects, other priorities, which includes delivery of innovative medicines. And this is what AstraZeneca, as well as some of the other pharmaceutical companies that have presented at this meeting, are also involved in that we are developing new medicines and looking at new indications within lung cancer to try and improve outcomes. And last but not least is a 3rd pillar, which we call enhancing the quality of care, which includes making sure that people and patients with lung cancer are supported adequately. So that means optimizing standards of care in each country, making sure that people are afforded testing to make sure that the right treatments are afforded to them, making sure that people are assessed in terms of a multidisciplinary team, which we've seen improves outcomes in lung cancer. So all 3 pillars are applicable, active, and we hope to apply across all countries. Next slide, please. But under early diagnosis, which is the focus of this meeting and this session, we want to drive something called stage shift. And as you may be aware, the situation in lung cancer and the reason why outcomes are so poor is that most people are present and diagnosed with lung cancer at late stages, stage 3, stage 4. So in this example, you see that 70% of the lung cancers diagnosed at stage 3, stage 4, with a 5-year overall survival of 20%. If we can drive early diagnosis, this is called stage shift, increase the proportion so that 45% of the people are diagnosed at stage 1, stage 2, then this will result in an increase in overall survival. And on the right, you see the strategies as to how we hope to be able to drive the stage shift. And it's really focused on low-dose CT screening, as well as management of incidentally found pulmonary nodules. And then also keep making sure that we're able to leverage new technologies. So that includes artificial intelligence, that includes computer-aided diagnostics. And also, you may have seen some new information that's coming out from Grail, from Delphi. These are companies working on blood-based biomarkers that hopefully will be able to diagnose lung cancer at earlier stages, as well as other cancers via a blood test. Next slide, please. If I may further expand under early diagnosis, it's a bill, so you can just click 3 times. Thank you. We have an area focused on low-dose CT screening. I mentioned the incidental pulmonary nodules, which is when nodules are found because of like an emergency room visit, and someone, because of a car accident, as an example, has ordered a CT. And the third is some data that's come out of Taiwan at the beginning of this year called TALENT, which shows that the epidemiology of lung cancer in East Asians may be different, and that there's a different risk criteria that needs to be considered. And so we're active in exploring all 3 of these areas in the appropriate countries. And one more slide, please. And perhaps you've discussed this already, but lung cancer screening is a very robust and well investigated area. There are 3 large randomized controlled studies that show that lung cancer screening does improve outcomes in people that are high risk. And we believe that we're at a tipping point. So it's not just the US that has approved lung cancer screening. We have Korea, we have Croatia, Canada is in a few provinces are approving this, and in countries in the EU as well as elsewhere, that those priorities in screening are being identified by policymakers. So we expect within Germany, the UK, Italy, and Australia within the next couple of years that screening will be approved. And we hope that Greece will be part of this list as well. Next slide, please. And one example is, a brief slide is that the UK, they've been also leading in implementation of lung cancer screening. And this is a recent paper that I urge you all to review. It really does show that the actual real world implementation of lung cancer screening can be done in a very cost-effective, in a very clinically effective manner. And you see that Haval Balada on the right is just showing some of the outputs from the actual review of 5 ongoing screening programs in the UK. You see a high level of clinical positive results in the high-risk population, as well that they're able to minimize some of the false positives, the overdiagnosis that had been raised as concerns with lung cancer screening. So I think what this slide and this study shows is that lung cancer screening can be implemented in an effective manner, in a cost-effective manner, and of benefit to people with high risk. And my last slide is really to show that the Lung Ambition Alliance is a worldwide partnership, that we have local partnerships in a number of countries. I'm proud to say that my colleagues in Greece have been leading and the partnerships that have existed, and I think this meeting is an example of this. But please know that there are efforts to improve outcomes in lung cancer around the world, and we really are at a tipping point. And I'm very confident that we'll be able to make advances for people with lung cancer around the world, as well as in Greece. So thank you for this opportunity.
Thank you very much, Gaius, for showing us what's happening worldwide regarding lung cancer. Thank you very much. Αυτό που βλέπουμε και αυτό που είδαμε.
What we see and what we have seen with Gaius Kim is that we shouldn't lose time. We saw what's going on in the world. So we need to change the terms of the game. The early diagnosis may save our life. This is the Lung Ambition Alliance message in AstraZeneca. This is implemented in our country with the participation of distinguished scientists and the participation of FairLife, among other agencies. Let's watch the video. Don't wait. Lung cancer is the most frequent form of cancer. It is responsible for the highest number of deaths as compared to other neoplasias. In its overwhelming majority, it is diagnosed at an advanced stage with a poor prognosis. Despite this, data from studies show that long-term survival for certain patients is feasible. 5-year survival rate for early stages diagnosed cancer may reach 90%. According to recent data, the screening with the help of low-dose CT can help diagnose cancer at an early stage. Low-dose CT may reduce the risk of lung cancer death by 24%. Don't wait. So in accordance with international data, up to 2,000 lives could be saved annually in our country. So learn about screening for lung cancer. Ask your doctor, don't wait, change the terms of the game. You can beat lung cancer. Don't wait. The European Lung Foundation is one of the most active organizations at a European level regarding the early diagnosis of lung cancer. We are really glad to have with us Kjeld Hansen, Chair of the European Lung Foundation, and Janet Rowlinson, member of Lung Cancer Patient Advisory Group, ELF.
For being with us today. We are very honored.
Thank you, and thank you so much for the invitation. So I have been watching a very excellent event, and I look forward then to speak on behalf of the European Lung Foundation, together with my colleague, Janet Rowlinson, who is very much involved in the patient advisory group for lung cancer in our organization. So next slide. First and foremost, a bit about who the European Lung Foundation is. So we are a patient-led organization that works internationally, and we work to bring patients and the public together with healthcare professionals to improve lung health and advance diagnosis, treatment, and care. So quite often, patients and healthcare professionals, they have the same end goal, but sometimes the means to getting to the end goal might be different. And that's why we involve patients who are the ones with most at stake in this situation. Next slide. So what we do then is we work with different kinds of organization on a multi-layered approach. So we are working to promote healthy lungs for life. We have the long-standing campaigns for the same issue, focusing on central aspects that can improve your life with lung health. We are also working to disseminate evidence-based patient information, and that could also be information that has been co-developed with patients in order to reach the target group better. We are the patient voice also at the ERS Congress. So many of our patients that are involved, and we have around 400 patients involved directly in our work, they are also the ones speaking on our behalf at big international conferences. So we also facilitate patient involvement in research, and Janet will testament to the same. We are involved in building multi-stakeholder communities. So we are working also on supranational structures where we are involved also in advocacy work with the European Parliament. So we do network in general, and we contribute to developing European standards and to work out joint statements and working together in emergencies. And I added then the example of the EU Cancer Plan, where we worked also with Luce and the ES to advocate for a stronger approach to early diagnosis of lung cancer earlier this year. So if you turn to the next slide. A few examples then of how we work with activities in lung cancer. So we are working continuously with lung cancer organizations such as FairLife and Luce, and we are working to have patients developing their priorities within lung cancer information, treatment and care. And we work then with our patient advisory group that is specifically directed towards lung cancer work. We are developing fact sheets on lung cancer screenings, and we are contributing the patient's voice to a paper on lung cancer screening as well. So you might see on this slide also examples of our joint statement with the ERS on our fact sheet on lung cancer screening, on our patients' priorities side on lung cancer, and then we have some of the people who are involved the most. And I will turn to Jeanette to speak more about the lung cancer patient advisory group.
Thank you, Kelt, and I'm delighted to be here today. And actually what I've heard in the session so far is borne out by many of the things we are experiencing in the UK. So I was asked to talk a little bit about my experience in lung cancer screening. So next slide, please. So the backdrop of Greece being one of the poorest performers, it was a surprise to me when I became involved in advocacy that all 4 nations of the UK are also bottom of the tables when it comes to the lung cancer outcomes. And so a lot of discussion has been held with a lot of people, obviously, to try and improve that situation. And what has become apparent is that screening or any intervention on its own is not enough. It must all be part of a longer term healthcare policy to recognise unmet need and inequalities and improve the UK position, or in your case, the Greek position, or in any other country where they want to improve the situation. One of the things about lung cancer is it is not only evidenced to be caused by smoking, but the incidences in area of deprivation are much higher than in other areas. So there are many inequalities going on here. We have learned that we must incorporate smoking cessation support service and a general prevention strategy alongside trying to pull the diagnosis forward in the pathway. There have been many concerns around overdiagnosis and anxiety, not helped by the long-term studies in the national screening of other cancers, such as breast, or studies into long-term effect of prostate, where radical interventions have made little difference to those who were merely observed. This is not the case for lung cancer, but it has had an impact in the discussions that we have had about trying to implement for the targeted population lung screening. It has been really, really driven, and I can't emphasize this enough, by a group of tenacious, stubborn, clinicians who have persuaded many policymakers that early detection saves lives. I've been party to some of these meetings with politicians, and their passion and their enthusiasm for making a difference at clinical and scientific level is palpable. I've listed there the timeline of my involvement. I don't intend to read all that out, but what I wanted to evidence was how long it is taking. And although I've heard many mentions and references to the UK today, let me make it clear, we do not have a national screening programme. We do not have coverage in many parts of the country, including the Midlands where I live, which is a population of 8 million and a very former industrial area. So although you may read the headlines, announcements are not actions, and it wasn't helped at all by the pandemic. But I was appointed after my diagnosis and radical treatment in 2011 to the National Cancer Research Institute Lung Group, where I was sent to the British Thoracic Oncology Group conference in 2014. And I broke into a group of men sitting discussing lung cancer screening. And I listened, not understanding anything they were talking about, and said, but what about the never smokers? I have never smoked. And they just said, well, we can't legislate for that. We've got to get it in for the majority at the moment and then see what happens. So I'm comforted that we are on the start of a journey. We had announcements made in the press before anything had really progressed. And then we had, if you like, unfortunate or fortunate, depends on the viewpoint, a minister, the Northern Ireland minister, developed lung cancer and was detected early and had a lobectomy and went back to work as the Minister for Communities, which actually helped our cause no end because behind the scenes he lobbied for screening. Sadly, he passed away last month. But when and if we do get national screening, we will all be raising a glass in his memory for all the work he did. Thank you, James Brokenshire. We've been involved with all sorts of announcements and reconfiguration and adoption by NHS England of the earlier schemes that have paved the way for this, the Liverpool Lung Project, Manchester's project, more recently London and Yorkshire screening projects. They are not called screening deliberately for two reasons. One, to confuse patients who won't turn up for something called lung cancer screening. So the MOT for your lungs, which is an annual examination people have to put their car through, the Ministry of Transport enables your car to be deemed roadworthy or not. So we say if it's good enough to have a checkup for your car, you need a checkup for your lungs if you were at risk, which has been well received. So I want to emphasize it takes patience, leadership, political will and collaboration. Next slide, please. So I've highlighted there the key things that were needed and are needed. We are not there yet. So extensive collaboration, as I've already said, driven leadership, a common purpose. We have had to agree standards. We brought in a national optimum lung cancer pathway. It is not followed in any single trust in its entirety yet in the UK, but it is an ambitious programme to harmonise the way we deal with lung cancer. We developed a national protocol for screening, which has been adopted by NHS England, and quality standards, and to look at how incidental findings are handled. And they differ across these pilot schemes. That's the point of pilots. The other thing I want to say is that not everything is done in those mobile units in the community. Some are done in hospital trusts. So the investment that people fear may not be needed. It may be possible through trusts, but the pilots will show us acceptability to the patients of the location. Really, I want to say that it is really important for everybody to work together, explore the evidence, learn from people already doing this, that's what we're doing, and have clear message of who this is aimed at. We have a long way to go, and we hope it will prove the case for a national rollout. But I would ask again, are you ready? Next slide, please. And here I've put some images because I was privileged to attend ERS congresses where free lung health checks were out in the community. And in a way, we've expanded on that. And so these are some of the mobile units in Leeds and Manchester, and also the notice that's put up in a communal area around what are the risk factors to help attract interest. Thank you very much.
Thank you very much, Kierit and Janet. Thank you very much both for sharing with us all your valuable experience and for paving the way for other countries and like us to follow. Thank you very much. Τώρα περάσουμε και στα
So moving on to our Greek speakers, Katerina Gotzogianni, President of the Greek Patients Association, who is going to address us via recorded message. Good afternoon. Thank you very much for the invitation. We know that lung cancer is the most common cancer in man and the third most common cancer in women, but it overall ranks first in the general population. It's certainly the deadliest cancer worldwide. Now, it is difficult to diagnose lung cancer at time as symptoms aren't apparent in early stages. Sometimes, even in the advanced stage, these usually appear when the disease has started to progress. In recent years, lung cancer cases are on the rise. As smokers, the highest risk group to develop the disease, increase. Lung cancer is, after all, 10 times more common in smokers than in non-smokers. Every year, 10,000 new lung cancer cases are diagnosed in Greece. Hence, prevention and early diagnosis play a crucial role here as well. FairLife's contribution is therefore very important, and Mrs. Patelis' effort is excellent. She managed to turn the pain and loss of her beloved husband into strength and a willingness to offer. The organization's vision is to support lung cancer patients throughout their difficult journey from diagnosis to treatment, and at the same time to raise public awareness about the causes of the disease, always aiming at prevention and early diagnosis. The Greek Patients Association will be by its side throughout this effort. I wholeheartedly wish this conference every success, as well as every other action that FairLife is planning. Thank you very much. So we had Katerina Koutsougian, and now we move on to Kyriakos Apostoli, the president of the Hellenic Cancer Federation and member of the board of directors of the European Cancer Patient Coalition. Ms. Apostolidou. Good afternoon. Thank you very much for this invitation. Indeed, we had a lot of significant things today, because we cannot speak about lung cancer without accepting that it is a major public health issue. And this has been has been said many times. Before I comment on what we've heard today, I'd like to say a few words about the Hellenic Cancer Federation, which is in operation as of 2016 officially. Of course, we've been working 10 years already, since 2011. We have 40 members around Greece, and we have an elected board of directors where the majority are patients. Now, our mission is to establish health policies on cancer and research on cancer. We seek to reduce the cancer burden on patients and their family, to improve outcomes and to improve quality of oncology care for patients. Our vision is to have a federation which is active, focusing on its mission in cooperation with all the members and partners for a future without cancer, making sure that every patient will enjoy high quality of diagnosis, treatment and care, rehabilitation and inclusion in social life. The ELOC, the Federation's strategy for the 3 years 2019-2022, consists of 5 axes: health policies, cancer research, training of our members, two-way communication between our members and all partners in oncology, both in Greece as well as abroad, and fair governance, proper governance. Sound governance. So we've been working throughout the years on cancer issues, and we heard today that lung cancer is the most important pandemic in cancer, since it is the first cause of death after cardiovascular diseases. What do we need to do? We need to have a complete universal lung cancer treatment program that will include prevention, early screening, diagnosis, treatment, rehabilitation, and inclusion. It cannot be dealt in a fragmented way. We each have to undertake a part of the required actions. But it is important to remember what Mr. Ioannis mentioned vis-à-vis prevention, awareness raising. There is no details information. Okay, cessation of smoking is not enough. We need to apply and implement all measures provided by the European Code Against Smoking. Things are quite simple. Suffice it for one to demonstrate the will. Smoking cessation, exercise, healthy diet, many fruits and vegetables, rather than processed foods. Quite a few things that people can start applying on themselves and their families. And here the state has a crucial role. They need to help social strata who are not familiar with the Code Against Cancer. They need to raise awareness and help people take action at a personal level. We need to have sport facilities, parks, where citizens will be able to enjoy sports, stay in the open air, to cut down on harmful emissions. Reduce climate change. These are issues pertaining both to the state as well as to every citizen. Now, regarding screening, we cannot but support screening. We already support screening quite strenuously, quite fervently. As most of our speakers might know, the European Commission has launched in the past 3 years the revision of the screening guidelines on breast cancer. This is to be finalized soon as the guidelines regarding quality control and assurance of breast cancer centers offering screening procedures is concerned. They have already started the same procedure regarding colon cancer. And these are really significant issues. And since I talked about quality assurance, I'm glad that Ms. Leonardo already has touched upon this issue. We're talking about centers that will be providing screening for lung cancer. Already, there are guidelines, there's the way. Pretty soon we will have guidelines on the modus operandi of breast centers regarding screening for breast cancer. Guidelines, rules, regulations, etc. All these are in common. They might be more specific depending on each type of cancer, but these are pretty much common rules. We are laggards in our country vis-à-vis screening. Now, regarding treatment, we heard a lot of speakers refer to biomarkers. Indeed, if there is one cancer where biomarkers play a predominant part, this is lung cancer par excellence, because it's not just one type of cancer. The features of this mass are specific, but we might have specific characteristics as well and different characteristics. This is necessary for the doctors to know, and it is necessary for patients to undergo the appropriate treatment that will directly respond to the features and characteristics of their own mass and get the treatment immediately. There's no time to lose. Now, the Hellenic Cancer Federation recently, within the Organ Greece platform, drafted 2 studies. One had to do with delays in initiating radiotherapy, and the second one pertaining to the delay of treatment, from diagnosis to the initiation of treatment. And the data we came across are really astonishing because they prove what we had found from experience. In cancer, there is a huge delay both in initiating radiation therapy, radiation treatment, as well as in initiating treatment as a whole. Delays from diagnosis to onset of treatment involve several steps in the path of patients. So delays are seen from the moment when the surgeons send the sample to the pathology lab. There are serious problems there due to lack of specialists, due to low number of human resources in pathology labs and hospitals. And this is where delays take place, which might be up to 3 months. This is unacceptable. We need to find a solution. The state needs to substitute pathologists who are in the process of retiring at central hospitals in our country. The state should encourage young graduates of schools of medicine to follow the pathologist specialty, because in a few years' time there won't be enough of them available. This is really serious because a delay of 3 months would mean further delays to the next steps. You need to assess an appointment with the oncologist. You need to come in contact. You need to discuss about it. It doesn't only take one appointment for a patient to be informed on the diagnosis and the treatment. The shock of the diagnosis is huge. There are many things that patients need to deal with, and usually as soon as they get the pathology report, it will take another 2 to 3 months until the onset of treatment. This, for cancer patients, is tragic. Treatment cannot be delayed. It has to be to start together with the diagnosis, of course. In order to have a proper diagnosis, we need to have the appropriate tools, and the appropriate tools are biomarkers.
Yes. Δεν αποζημιώνονται.
We have only a few biomarkers in our country. Not all biomarkers fall under the reimbursement scheme. Not all patients are aware of the role of biomarkers. They can't understand why doctors prescribe these and all the other biomarker. It's not just a Greek problem, it's a European issue, and this is why last year in 2020 we held a European study, the survey by IQ and Path, ECPC. I'm a board member of the ECPC and I've been president for many years, and from FPR. And there was a survey conducted in all member countries of the EU and the UK in order to see whether biomarkers are in use, which biomarkers, or whether they use the next generation sequencing, whether patients are aware and familiar with the biomarkers and the next generation sequencing. What kind of path do the preparations from the OR to the pathology lab follow? What is the methodology for the analysis of the sample until the drafting of the report? A very detailed and very specific report which drew conclusions regarding policy on biomarkers and policy on the treatment of cancer, because without the biomarkers, particularly in cancers such as lung cancer, it is very difficult to focus on the right drug for the right patient. The results of this study, of this survey, were presented by the Hellenic Cancer Federation in July in an event we had organized, and only recently, in October, we presented the results from this report, which has been translated into Greek, and it is available for you if you ask for it. I'm showing you here. I don't know if you can see it. This is the report, and it is available. The end of treatment is not the time when we take the last pill or when we undergo the last chemotherapy. We need to have a psychosocial support of patients right from the start, right from the diagnosis, because such a serious diagnosis, which is life-threatening, disturbs the patient's mental status. Patients and their family should enjoy the support, should have psychological support so that they can respond and so that they can assimilate what's happening to them and get ready for undergoing treatment and this whole course that they need to walk with several tests for quite some time. Even after the end of treatment, which, as I said, is not when you take the last pill, patients need to receive support and have rehabilitation so that they can be return to their social activities or to their work. Unfortunately, we're lagging behind all these sectors, as is the case with palliative care. Unfortunately, our country has no palliative care structures, and patients for whom there is no other line of treatment available have no other solution than returning from hospital to home or to seek private bodies that can help them. This is unacceptable. Cancer is a single entity from the beginning till the end, whatever this end might be, and we need to help have the help of the state. All this is included in the European Cancer Plan, starting from prevention, screening, treatment, rehabilitation, and inclusion, the survivorship. All this is really important. I don't want to take more of your time. Thank you very much for the invitation.
Thank you very much, Mrs. Apostolidou. She told us what needs to be done by the patients. And let me now move on to Zoe Gramatoglou from KEFI. Mrs. Gramatoglou, good afternoon. Good afternoon, ladies and gentlemen. I would like to thank FairLife and Mrs. Patelli for inviting me to speak to you today. A lot of very interesting things were mentioned. I hope that all goes well. I won't talk about what needs to be done or what should have been done. I've mentioned all this many times over, and Mrs. Apostolidou actually took the words out of my mouth. I'm covered from what she said. What I hope is that there will be collaboration with public hospitals, because if something happens at Metropolitan, I know they have a great team and they've got great results from the research we presented. But what about from now on? What will happen from now on, as of tomorrow? Will public hospitals be able to support all this? And I remember what was mentioned today, and I will dwell on this. It's a very good program. So let's get it right this once. Let's get it right this time. In my humble opinion, this will happen if we have the participation of public hospitals in the program. So, however, in public hospitals, we don't have trained doctors wherever they have respiratory departments. So they will need to approach people so that they can go get screened. But there is no culture in Greek society when it comes to screening. So the state must take action. It must train the doctors first so that the doctors can approach the patients and persuade them to undergo screening. So there must be a political will. Now, with digitization of the healthcare system, the time is ripe so that people can get a message on their mobile phone that they have to go for screening, that your time has come for a lung CT. It's not that you will happen to find that you have lung cancer because you went for some other test. So what was good about breast cancer, about screening for breast cancer, is that we have the mobilization of patients, but also of the scientific community. And we breast care patients survive more than is the case for other types of cancer. So I'd like to say that we had patients, advisory groups. We in KEFI have been working for cancer, and every year we have this anti-tobacco campaign. We have helped reduce smoking by providing information to the general public, because a lot of things are mentioned at conferences, but does this trickle down to the audience? Who will knock on the door of the citizens saying that you need to do this, this, and that? And here I think it would be a good idea, just like we have the mobile units for mammograms or pap tests, cervical smears, to go to the rural areas where people might have never had a lung CT. So I think that this is possible, provided there's the political will for this. So we have helped in all matters related to cancer, not just breast cancer, but also lung cancer. So we're here to provide our support and raise awareness among patients, because this is our role. This is our role, and then scientists can play their role. They can approach the patients and actually persuade them to go for screening. I will conclude. So let's do it right this time, since we're starting from scratch, and I hope that the Doxiadi program will be successful, and congratulations to Corina for everything she's done so far. And we are here to stand by your side so that we can all walk down this road together. Thank you very much for all the practical things that you told us, things that need to be done, and things that people need to know. With Mrs. Gramatoglou, we've come to the end of this session regarding patients' groups and patients' associations. Before we move to conclusions, we will watch this 45-second spot, which highlights the importance of early diagnosis of lung cancer, because 1 out of 4 patients that die from cancer are patients suffering from lung cancer. So 1 in 4 people that die of cancer are lung cancer patients, 1 in 4. So lung cancer is a threat for all of us. 85% of cases are smokers. I was able to survive. I might have been a little bit late, but I survived. So low-dose CT is the indicated form of screening for lung cancer. The best prevention is to stop smoking. A timely diagnosis is the most important way to save human lives. We inform, we prevent, and we support. Life, let life take your breath away, and not lung cancer.
Dear friends, today we heard a lot of things. Now, before I give the floor to the president of FairLife to conclude with this meeting, I'd like to share with you some of my notes. Now, we heard the minister, Ms. Minagaga, mention that the Ministry of Health is in cooperation with and the Hellenic Thorax Society to create a structured plan. We heard the rector. Unfortunately, there is a sound. So I will repeat. We heard the rector of the National Kapodistrian University of Athens talk about the three tools we need: the criteria for the reimbursement of CT scans, further dissemination of the diagnostic algorithm, and improvement of the labs, and appropriate examination of biomarkers and liquid biopsy establishment. The survey showed that the screening may save lives, 3,500 lives in 5 years' time. These were lives that would have perished. Also, the survey showed that rates quite close to the conclusions seen by other countries, and given that we have high smoker rates in Greece. This is important. So it showed that if lung cancer is diagnosed at stage 1, it has 92% probability of cure. The discussion that followed showed the following. We are ready, we have scientific evidence, we do have the know-how, we have scientific adequacy and proficiency, and we have the support of scientific community. What do we need? We need to organize special centers for screening in the form of lung cancer centers, relevant or similar to the ones we have on breast cancer. And we need training of those who will be involved in this whole process. We heard about the drug industry. They are ready to support the screening process. We heard patient associations, societies and federations from Europe, the US and Greece. Foreign patient societies shared with us their efforts to create a screening program, emphasizing the fact that the involvement and participation of all those stakeholders was important. The Greek patients' societies repeated the need to have a universal screening program for lung cancer and asked that the statements of the state become practice, are put into practice. So these are my own conclusions. And with that, I'd like to warmly thank you for having attended this event and give the floor to the president of FairLife, Ms. Corina Patelibel, who is going to close this important event. Thank you.
Καλησπέρα σε όλους. Φτάσαμε.
Good afternoon, everyone. This signals the end of today's event, giving answers to the question prevention and early diagnosis of lung cancer in Greece. Are we ready? We have analyzed the results of the survey, and through a creative dialogue, all parties involved agreed that the screening for lung cancer should constitute a priority in our country as well regarding the national health system. Now, this priority has to be put in practice, and if it is put in practice, many human lives will be saved and spared. Lung cancer is a major public health issue. My own personal belief is that next year we will be able to have steps taken towards this direction, because we do have the knowledge, the maturity and the data required to launch the first pilot projects for the broader public. So one step at a time should be enough if we want things to move forward. This is my own personal motto. I'd like to thank all those who participate in FairLife's work and inspire us and help us and encourage us to have a vision. Just envision a situation whereby all cancers would be prevented. We do have that vision. We dare to dream of a world without cancer. So we will conclude with the message of hope coming from our own children, our future. So they ask us to give them a world without cancer, without addictions such as smoking, sending us the message of hope. 14 minutes of life. I thank you all from the bottom of my heart.
Δεκατέσσερα
14 minutes for the love of the game. 14 minutes of skate in order for life to take your breath away and not lung cancer. So knowledge saves lives. 14 minutes for my passion. Every day, life takes your breath away. After studying, 14 minutes with my friends, that's what gives me joy. Vaping, smoking, no, I want 14 minutes for me. 14 minutes roller skating in order for life to take our breath away and not cigarettes. 14 minutes of going for a ride with my bicycle. We put a brake on cancer. 14 minutes of reading my favorite book in order for life to take my breath away and not cigarettes. Προτιμώ να περάσω 14 λεπτά από τη ζωή μου κάνοντας αυτό. Don't miss a minute of your life. After a difficult and tiring day, 14 minutes of playing with my dog is exactly what I need. What do you know about vaping? What do you really know about vaping? 1 in 4 students, 81% of young people, 15,000 different tastes that trap you. Electronic cigarettes contain addictive nicotine. Don't do it. I hope that no child in the world will lose his parent from lung cancer. Let life take your breath away and not lung cancer. FairLife thanks these students for the videos.